Friends, now let us start the discussion of or revision of the important points of the nose and paranasal sinuses in ENT. The first thing is lateral wall of nose, very important topic, and I'm sure you remember that lateral wall of nose, when we used to draw it like this in the class also, in the app also, that there is something called turbinates on the lateral wall of nose, which are the projection on lateral wall of nose, and there are three turbinates: inferior turbinate, middle turbinate, and superior turbinate. And every turbinate has got a space below that, and the space is called meatus. This is inferior meatus, this is middle meatus, this is superior meatus. And the area above the superior turbinate is called sphenoethmoidal recess. Okay, what is SER? Sphenoethmoidal recess. So turbinate is clear. Meatus, what is turbinate? Projection on lateral wall of the nose. What's the meatus? Space below the turbinate. What is the SER? Sphenoethmoidal recess. Its area above the superior turbinate. Now, in the real endoscopy picture, now please see, this is your lateral wall of the nose. Okay. Now, this is your inferior turbinate, and this space is called inferior meatus. Inferior meatus. Similarly, over here in this picture, this is lateral wall of the nose. This is your middle turbinate hanging projection from the lateral wall, and this is the middle meatus. Okay, this area is called middle meatus. Now one more concept is, what is concha? C-O-N-C-H-A. What is concha? Concha is the bony part of the turbinate. Within the turbinate, there's a bone, and that bone is called concha. So there are three concha: inferior concha, middle concha, superior concha. Concha covered with mucosa, and some mucosa becomes the turbinate. And of course, you can see over here, this one. Can you see over here, beautiful inferior concha? Yes. And if I cover the inferior concha with the mucosa, it will become the inferior turbinate. And this space, of course, my dear friend, this space will be what? Inferior meatus. Am I clear? Inferior meatus. Now guys, let us discuss what are the various structures which are draining into nasal cavity into different areas. Now, first of all, what drain to the inferior meatus? In the inferior meatus, nasolacrimal duct drain into inferior meatus. Into middle meatus, what drains? Maxillary sinus, frontal sinus, and anterior ethmoid air cells. What drain to superior meatus? The posterior ethmoid air cells. And what drain into the sphenoethmoidal recess area? The answer is sphenoid sinus. Let's revise once again. The nasolacrimal duct drain into the inferior meatus. Maxillary sinus, frontal sinus, anterior ethmoid air cell drain into the middle meatus. Posterior ethmoid air cell drain into the superior meatus. And sphenoid sinus drain into the sphenoethmoidal recess area. Now, one important question of ophthalmology. Let us do one ophthalmology question also. The DCR, dacryocystoreostomy surgery done for the chronic dacryocystitis patient. Where do we make the surgical opening of DCR? In the middle meatus. In the middle meatus. And one visual question of ENT. This is Harrison's endoscopic DCR bone punch, which is used for the endoscopic DCR, which is done by ENT department endoscopically through nose. So DCR is being done by ENT people also through nose endoscopically, and this is a very famous instrument of that, which was asked in the visual question. The answer is, identify the instrument, Harrison's endoscopic DCR bone punch. So this is a picture of that. Okay, now this lateral wall of nose specimen can be shown in the picture. Now let me label it for you. It's a cut section of the lateral wall. You can see the directly end on the lateral wall. This is your inferior turbinate, and this is your inferior meatus. Inferior meatus. Okay. Now this is your middle turbinate, and of course this is the middle meatus area. And this is small one is superior turbinate here, and superior meatus is little bit visible over here. And that's a sphenoethmoidal recess area. The main thing is this is sphenoid sinus. So they have asked one question: what drain in this area? In the sphenoethmoidal recess area, the answer is sphenoid sinus. Okay, fine. Now, again, one more lateral wall. This they can show you this one also in the paper. This is inferior turbinate, middle turbinate, superior turbinate, and this is which sinus, beta? Sphenoid sinus, and drain into which area? Sphenoethmoidal recess area. Don't forget to revise the lateral wall of the nose cut section as a cadaveric specimen, which can be asked in examination. Now let's go further. Yes, sphenoid sinus is important. Beta. Why? advanced question can come. And where is the sphenoid sinus? It's lies in the body of the sphenoid bone. Where is the body of sphenoid bone? This is the body of sphenoid bone. In this area, there are two chambers, hollow cavities, which are sphenoid sinuses. Guys, if you remember, the uppermost part of the body of the sphenoid bone has a depression called sella turcica. In the sella turcica, we have a gland called pituitary gland, and the patient may develop the adenoma of the pituitary gland. So what is the best surgical approach for, now the question is, what is the best surgical approach for pituitary adenoma surgery? Is it neurosurgery? No. We can go through nose. How? Because we know if you go through nose, for example, please see in the lateral skull x-ray, if you see, you can go through nose like this transnasal endoscopically, you can enter, this is your sphenoid sinus. Your either sphenoid sinus, can you see this depression? This is sella turcica. So you can, there's a gland here, that gland is a tumor. So you can go through sphenoid and reach the gland straight away. Rather than neurosurgery, we can do the pituitary adenoma surgery. The best surgical approach nowadays is, the answer is endoscopic, transnasal, transsphenoid hypophysectomy. Okay. So the best surgical approach for pituitary adenoma nowadays is not neurosurgery. It is the ENT route actually. It's endoscopic, transnasal, transsphenoid hypophysectomy, because you are clear anatomy wise that okay, on top of the sphenoid sinus there is pituitary gland. To reach sphenoid is very easy through the nose, and we can go endoscopically through nose. We reach the sphenoid and we open the roof of sphenoid and we remove the pituitary gland also through this route only. So the best surgical approach for pituitary adenoma nowadays is endoscopic, transnasal, transsphenoid hypophysectomy. Development of sinuses is important. Now, please understand. First of all, what is the sequence of development of sinuses? Answer is MESF. Maxillary, ethmoid, sphenoid, frontal. Now, next question is, the first sinus to appear in humans is maxillary. The last sinus to appear in human is frontal. Which two sinuses are present at birth? The answer is maxillary and ethmoid. Which is the most developed sinus at birth? Ethmoid. Sphenoid develop at what age? 4 years of age, radiologically. And the frontal appears at 6 years of age, radiologically. So these are various points you need to remember about the development of sinuses. Okay? Next question. What is choana? Choana is the posterior opening of the nasal cavity, not concha. Concha is the bony part of the turbinates. Choana is the posterior opening of the nasal cavity. Sometimes the choana may be blocked. Can you see over here? You can see over here the choana may be blocked. This is the normal choana. And in this case, you can see this is the case of choanal atresia. It can be unilateral, but look at this case. Very dangerous skin. It's a bilateral choanal atresia. Very famous question of ENT pediatrics. Bilateral complete choanal atresia is a neonatal airway emergency. Why? Because neonates are obligatory nasal breathers. Now this child will be sinosed right at birth. But the moment baby tries to cry, baby cries actually, the baby turns pink. Why? Crying is a deep inspiration with the open mouth. Okay? The lungs are normal. There's no cyanotic heart disease. So crying means deep inspiration with open mouth. Suddenly, the blue baby turns pink on crying. That's a very important clue for choanal atresia. Okay? So blue baby turn pink on crying is the clue for choanal atresia. The pediatrician would be unable to pass the suction catheter through the nose. When the baby is received by the pediatrician, they clear the amniotic fluid with the catheter. In this baby, the pediatrician is unable to clear the amniotic fluid properly because the suction catheter cannot go to the pharynx, to the nose, because this is choanal atresia. It's a very serious airway emergency if it is a bilateral complete choanal atresia. Okay, the immediate management is put a wide bore nipple in child's mouth to keep it open, and this is called McGovern technique. So McGovern technique, very famous question. This is used for the immediate management of choanal atresia baby. To save the baby, you put a wide bore nipple in child's mouth and wait for the ENT doctor to come. After few minutes, ENT doctor will come and he will do tracheostomy. And after 1 year of age, we do the proper recanalization surgery and we apply which drug? Mitomycin C, to make sure the opening is still patent after surgery. Okay, very famous question. So blue baby turns pink on crying. bilateral complete corneal atresia. Don't forget McGowan technique, wide bore nipple picture also. Okay, now external nose. The external nose is only upper part is made by nasal bones. Then we have got upper lateral cartilages. Then we have got lower lateral cartilages. What are they? They are lower lateral cartilages. And then very small, we have got the lesser alar or sesamoid cartilages. So only the upper one third is made by the bone. Remaining whole thing is the cartilage. And this is also a multiple choice question of the anatomy. So this is the design of the external nose. You can see very clearly. Number one is nasal bone. Okay. And only upper one third part only. Lower two third is cartilage. What is that? Upper lateral cartilage, lower lateral cartilage, also called alar cartilage. And number four, these ones are the lesser alar or sesamoid cartilages. Now, Cottel's test pictured. Now, it is done to check the blockage of nasal valve. So, this is nasal valve area. Sometimes the valve is collapsed. If they show you a visual picture, keep the two finger on the cheek lifted upward. What is the name of this test? Cottel's test. Cottel's test is done to check the blockage of what? Nasal valve. Visual question. Now, nasal trauma is a very commonly thing asked. There will be always history of trauma followed by some deformity of the nose. You order the X-ray of the nasal bone, lateral view right and lateral view left. And in this, you can see over here also, there is a fracture of the nasal bone in this patient. Now, there are two types of question possible. In one question, they will say there is no swelling of the patient. If the no swelling is mentioned, then the treatment of choice is immediate close reduction before edema starts. Immediate close reduction before edema starts, and this is done with the help of which forceps? Walsham forceps. This is done with the help of which forceps? Walsham forceps, my dear friend. And if edema is mentioned, if swelling is mentioned in the MCQ, then wait for 7 days. Let the edema subside and then do the same procedure, but after swelling has subsided. So, nasal bone fracture, two questions are possible. If swelling is not mentioned, then immediate fracture reduction. If swelling is mentioned, then wait for 7 days and then do the fracture reduction. But the forceps is same. The name of forceps is Walsham forceps. CSF rhinorrhea is a very important topic. CSF rhinorrhea, the common causes are, number one, the most common cause nowadays is iatrogenic, means surgery like functional endoscopic sinus surgery, FES. Second common cause is head injury, trauma, skull-based fractures. If you remember, we discussed in the class also, Lefort 2 and Lefort 3 fracture and nasoethmoid fractures are very commonly linked with the CSF rhinorrhea. And third are spontaneous idiopathic leaks also. Now, one visual question is target sign or halo sign. Target sign or halo sign. T for target, T for traumatic. Target sign or halo sign is a feature of traumatic CSF leak. Why? In head injury, in skull-based fractures, there is a CSF leak, but this leak is blood mixed CSF. So when a drop of that falls on the filter paper, after drying, it leaves a red spot and a halo around that. This is called target sign or halo sign or double halo sign. These all are a feature of what? Not every CSF leak, only of traumatic CSF leak. Now, what is the commonest site of CSF leak? And this can be a visual anatomy question also. This answer is cribriform plate. The overall most common site of CSF leak is cribriform plate, and this instrument is showing the area of the cribriform plate also. But if the MCQ particularly asks you what is the commonest site of leak of CSF in traumatic cases, traumatic CSF leak, the answer is the fovea ethmoidalis, which is the roof of the ethmoid bone. Okay, so the overall commonest site of the leak is cribriform plate, and the commonest site of particular traumatic CSF leak is fovea ethmoidalis. Now, how to confirm it is CSF only coming from your nose? Number one is you cannot sniff back CSF. Number two, CSF is non-sticky like water. Number three, that you can do biochemical analysis, look at the glucose level, chloride level, etc. But still, if there is doubt, the best confirmatory test for CSF rhinorrhea is beta-2 transferrin estimation. Guys, beta-2 transferrin is only found in the CSF. It is not found in the nasal secretions. Now, how to find the site of leak? Now, you can do the nasal endoscopy, of course. You can not see CSF because CSF is actually transparent white. It's like water. So before you do endoscopy, you can inject which dye through lumbar puncture. The name of dye is fluorescent dye. Fluorescent dye. So first you give intrathecal lumbar puncture injection of fluorescent dye, followed by nasal endoscopy. This dye will give green color to CSF. It is easy to see on the endoscopy. But we do a lot of radiological investigation also to find the site of leak. The number one will be MRI T2 images. T2 images. Number two is CT cysternography, which is invasive radiological investigation in which a radio contrast dye is injected through lumbar puncture and followed by a CT of the head actually. But the best radiological investigation for this case is HRCT skull base. If they ask you what is the best radiological investigation to find the site of CSF leak, is HRCT of the skull base, high resolution CT of the skull base. What is the treatment of choice of CSF rhinorrhea? Don't go for surgery, beta, to close it. The treatment is conservative treatment with bed rest and antibiotics for 7 to 10 days. You don't want meningitis to develop, give antibiotic, but give the nature a chance to heal those fractures, because callus formation might prevent the CSF leak in many cases. So why to jump on a surgery immediately? So the treatment of choice is conservative treatment with bed rest and antibiotic for 7 to 10 days. If leak does not stop after a week or so, then you think of the surgery. But the primary treatment is not surgical, conservative treatment. Now, next clinical scenario, foreign body in the nose. Foreign body in the nose, again, very famous question. There is a 7-year-old child presenting with this child has put the foreign body few days back. Now, the foreign body in a school-age child may be missed. Child may not tell the parents actually. Now, this infected foreign body will start emitting bad smell. 7-year-old child, with unilateral foul-smelling nasal discharge and epistaxis. Single-side smell, single-side pus, single-side blood. In a school-going age child, it's indicative of there is inside the nose some old foreign body there. Very famous question. And don't forget, school-age child with smell from the nose, bleeding from the nose, a pus from the one side of the nose is foreign body question for sure. If it's a disc battery in the nose or in the esophagus or in the bronchus, anywhere, disc batteries, please remove them urgently. Because these are active batteries, these are alkaline batteries, and alkaline batteries can release, of course, alkali, and alkali causes necrosis. And if a patient has swallowed the battery, esophageal foreign body as a battery, it can lead to esophageal perforation. So batteries should be removed urgently. Now, look at this picture of, right? You remember Otrivin, Nazivion, these nasal decongestant drops are OTC products actually. Xylometazoline or oxymetazoline, they are good drugs for a few days, but if you do prolonged use of xylometazoline or oxymetazoline, it leads to disease called rhinitis medicamentosa. Because if you use these drops for weeks and months, your system get dependent on that. There is a reflex vasodilatation after the effect of this drug is over, and that leads to huge problem for the patient actually. Rhinitis medicamentosa is due to prolonged use of topical decongestant drop like xylometazoline or oxymetazoline. Again, a visual question, basal cell carcinoma or rodent ulcer. If they ever show you an ulcerative like lesion like this, like this with rolled out edges on the nose or the pinna skin, on the nose, external nose or the pinna. Anytime they show you ulcerative lesion with rolled out edges on the nose or pinna, the primary thing come to your mind as the first choice should be basal cell carcinoma or rodent ulcer. Okay, fine. Now, rhinophyma, another visual question of dermatology ENT. Rhinophyma or potato nose is not a tumor. It is hypertrophy of the sebaceous gland of the skin of the external nose. It's hypertrophy of the sebaceous glands of the skin of the external nose. I'm clear to define. It's not a tumor. It's not a tumor. It is a hypertrophy of the sebaceous glands of the skin of the external nose. Now, let us do a clinical scenario. A young patient, mostly a female, generally they give a female, with a roomy nasal cavity, nasal crusting, bad smell from nose. Absolutely, it's a case of atrophic rhinitis. My dear friend, I'm sure you remember, atrophic rhinitis is more common in females. And it is also called ozena. And the name of the bacteria to be remembered as a culprit is Klebsiella ozene. There's a bad smell from the patient, but patient has anosmia. So this is called merciful anosmia. Don't forget, merciful anosmia is a feature of atrophic rhinitis. Patient emits bad smell, but patient cannot smell anything. generally a female patient with the wide roomy cavity with a lot of crusting in the nose, bad smell from the patient, but patient cannot smell anything. This is called merciful anosmia, and the treatment of choice is alkaline nasal douching, and the alkaline nasal douching powder contains number 1, sodium bicarbonate, number 2, sodium biborate, and number 3, sodium chloride. Sodium bicarbonate, sodium biborate, sodium chloride. And what are surgeries done? Young's operation, modified Young's operation, and Luton-Slager operation. Don't forget this picture of the modified Young's operation. When the doctor is stitching the front end of the nose, visual question also, it is modified Young or Young. What is modified Young? It is partial closure of both nostrils. Okay, so in which disease you stitch the nostril from the front, atrophic rhinitis, and the name of surgery, we don't do Young's nowadays, we do modified Young, we do partial closure of both nostrils at the same time, and this is a permanent procedure. Now, guys, atrophic rhinitis does not have any external changes in the nose, of the skin of the nose from the outside, whatever is there is inside the nose. But if the MCQ looks similar, again, a young patient with roomy cavity, with nasal crusting, but along with that, there is a hard external nose. So it is, question is looking like atrophic rhinitis only. But along with that, the hard external nose also mentioned. The answer will change to rhinostroma or woody nose. Rhinostroma or woody nose. Guys, if you remember, rhinostroma or woody nose, which is caused by Klebsiella rhinoscleromatis. It is more common in North India like Uttar Pradesh and Rajasthan states, and it has 3 stages. The first stage is atrophic stage, and that stage has got a feature resembling the atrophic rhinitis. Second stage is granulomatous stage, and that lead to hard external nose. That is why it is called woody nose. And third is stage of fibrosis. Okay, and don't forget the histopathological finding of rhinostroma. The classical findings are Russell bodies and Mikulicz cells. Russell bodies are blue cells, solid plasma cell like inclusion bodies, and Mikulicz cell, please see over here, Mikulicz cell are these cells. These are the Mikulicz cell. They are the large vacuolated cells. Okay, Russell body, Mikulicz cell are feature of rhinoscleroma. Okay, fine. And what is the drug of choice? Drug of choice for this patient will be tetracycline plus streptomycin. Tetracycline plus streptomycin. So, two histopathological findings of rhinostroma, Russell body and Mikulicz. Rhinoscleroma, R for Russell body, rhinoscleroma, M for Mikulicz cell. What is the drug of choice combination? Tetracycline plus streptomycin. What is the second line drug for rhinoscleroma? Rifampicin. Let us do another question. Rhinosporidiosis. So, a lot of rhinosporidiosis. First of all, S. It is seen in South India, the particularly coastal part of Tamil Nadu. My dear friend, rhinoscleroma is from North India, Rajasthan, Uttar Pradesh. Rhinosporidiosis patient history will be South India patient, Tamil Nadu, coastal area. Second is S, C. Coastal area, C. It is caused by Rhinosporidium seabrai. C, water. It is aquatic protozoa. Okay, aquatic protozoa. Third S is swimming. There will be history of swimming in the ponds. Basically, it is found in the pond water. It is aquatic protozoa. Rhinosporidium seabrai, water. It is an aquatic protozoa. It is not a fungus. It is S for swimming. There is a history of swimming or bathing in the ponds. And fourth S is strawberry-like or mulberry-like nasal mass. You can see in the picture also, strawberry-like or mulberry-like nasal mass with epistaxis. Treatment is surgery, and the drug of choice which is given after surgery is Dapsone. Rhinosporidiosis has got D for Dapsone, Rhinoscleroma has not D, Dapsone is used for which disease? Rhinosporidiosis. Rhinosporidiosis, D is there, D for Dapsone. Okay, fine. Rhinosporidiosis. Now, Ongral line, another famous question. Ongral line is used in which cancer? Cancer of the maxillary sinus. Is it used for surgery? No, it is used for assessment of prognosis. What is Ongral line? Ongral line is from medial canthus to the angle of mandible. Ongral line is from what to what? Is from medial canthus to the angle of mandible. It is used in which cancer? It is used in cancer of maxillary sinus. Is it for surgery? No, it is for the prognosis assessment. What is the significance of the line? Any cancer of the sinus or maxillary sinus, any cancer line above this line will have poor prognosis because of early orbital involvement. So, Ongral line, let's revise, it's from medial canthus to angle of mandible. It is for the prognostic assessment of cancer of maxillary sinus. The cancer lying above this line will have poor prognosis due to early orbital involvement. Next question, beta. Inverted papilloma, very famous question, also called as Ringet's tumor. Inverted papilloma or Ringet's tumor, very famous question again. And this is a benign but locally invasive tumor. It's aggressive tumor. It's inverted means it grows inwards. Therefore, it's a locally spreading tumor and it has got chances of malignant transformation in 10% cases. Once again, inverted papilloma of the nose, also called Ringet's tumor, it's a benign. Papilloma is a benign. Inverted means it grows inward histopathologically. Therefore, it's called inverted, by the way. Why it's called inverted? Because it's growing inwards, it's called inverted. Number two, it's growing inward, therefore, it's a locally invasive tumor. It's aggressive tumor. Number three, it can show malignant change in some people. Okay. What is the site of origin? The site of origin is lateral wall of nose. Please see over there. The site of origin is lateral wall of nose like this. This is the site of origin, lateral wall of the nose. So this is a papilloma, inverted papilloma originating from the lateral wall. As I told you, this grows inward, inward. So if you want to just remove the tumor only, please understand, if you remove the tumor only like this, don't you think so? Some tentacles are still left. Okay, so we will have to do bigger surgery. Beta. How? We'll have to remove the site of origin also. We have to remove the site of origin also. What is site of origin? Lateral wall of nose. So you remove this much wall also. Guys, the lateral wall of nose is equal to medial wall of maxilla. Lateral wall of nose is equal to medial wall of maxilla. So what is the name of surgery? The name of surgery is medial maxillectomy. So in which condition in ENT we're doing surgery called medial maxillectomy? The answer is inverted papilloma of nose. It arises from lateral wall of nose. Lateral wall of nose is nothing but medial wall of maxilla that needs to be removed because it's a locally aggressive, locally spreading tumor. So that's why the name of surgery is the medial maxillectomy. Now, synecdoche. The most common complication, the most common long-term complication of nasal surgery is, the answer is synecdoche formation of the nose or adhesion formation of the nose. My dear friends, you can see in the picture also, this is your inferior turbinate, this is your septum, and this is the synecdoche. So most common long-term complication of any nasal surgery is synecdoche or adhesion formation because raw areas fuse with each other. How to prevent the synecdoche formation in the nose? The answer is mitomycin C. The topical application of mitomycin C reduces synecdoche formation. This is a very famous question again. Mitomycin C is used in laryngotracheal stenosis also, choanal atresia management also, and in this case also, because this is anti-cancer drug with additional anti-fibroblastic properties. Okay, so which drug is used to prevent the formation of synecdoche? Mitomycin C. Pott's puffy tumor, very important question again. Pott's puffy tumor is a complication of acute frontal sinusitis. Now, frontal sinusitis, which is the infection of mucosa of the frontal sinus, can go deeper into the frontal bone over here, and that will lead to frontal osteomyelitis, and that frontal osteomyelitis will lead to the subperiosteal frontal abscess, and that is called Pott's puffy tumor. It's not a tumor, it's a pseudonym, so that's why it's asked very commonly. It's a misnomer. Pott's puffy tumor is subperiosteal frontal abscess, which is generally formed as a complication of frontal sinusitis. It presents as painful red forehead swelling as visible in this image as well. Very famous. Don't forget, Pott's puffy tumor is not a tumor. Okay. Now, again, very commonly asked in the exam is Waters view, sinus X-ray beta. What is the most commonly done X-ray for sinuses? Waters view. What is the best X-ray for sinuses? Is Waters view. Waters view is technically which view? Occipitomental view. Water view can be done with the open mouth also, which is better. Water view, when done with the open mouth, is called Pieris view. Water view shows which sinus the best. Answer is maxillary sinus. Water view shows all sinuses except posterior ethmoid. Once again, the best X-ray view for sinuses is Waters view. Waters view is occipitomental view. It is done mostly with open mouth. When you do water view with open mouth, it is called Pieris view. The best sinus visible on water view is maxillary sinus. Water view shows all sinuses except posterior ethmoid. Okay. Now please see over there. Let us see. This is your O for orbit. This is your M, maxillary sinus. Okay. This is your frontal sinus right above the orbit, and through the open mouth you're seeing what S. What is S? Sphenoid sinus. Sphenoid sinus. So no confusion. PRS view is nothing but water view with open mouth. Okay. Now another view for sinus is Caldwell view, which is rarely done. Now Caldwell view is technically occipito-frontal view. Water view is occipito-mental view. Occipito-frontal means more like this. Caldwell view is the best X-ray view for frontal and ethmoid sinuses. The best X-ray view for the maxillary is the Waters view. The best X-ray view for the frontal and ethmoid is the Caldwell's view. And the best X-ray view for sphenoid sinus is X-ray skull lateral view. But Caldwell view cannot be confused with the water view. Why? Because in Caldwell view, if you see carefully, maxillary sinus is hardly visible. But if you compare both the views over there, please, this is of course maxillary sinus very clearly visible. It has to be Waters view. So if you ever get that which one is water view, just look at the maxillary sinus. If clearly visible, it is water view. If it is not clearly visible, then it is Caldwell view. It is highly unlikely Caldwell view will be asked in the paper. Generally, they ask you water view. Water view can be done with open mouth, can be done without open mouth. When done with open mouth, which is better, it's called PRS view. So look at the choices. Okay, fine. Carefully. CT scan. They can ask you CT scan also. This O for orbit. Okay, O for orbit. And right below the orbit, which sign is there? M, maxillary sinus. What is this turbinate? IT, inferior turbinate. Okay. What are these cells between the two orbit? Ethmoid. Very good, ethmoid. So these are ethmoid air cells. Okay, fine. Now, let us discuss ethmoid air cells now. Ethmoid is a single bone in the body between the two orbits. It's a single bone in the body between two orbits. This is your ethmoid bone. Single bone. Not two bones, not two bones. Single bone in the body between two orbits. And of course, there are many air cells in that. These air cells are called the ethmoid air cells. Okay, fine. Now let us see ethmoid air cells. Ethmoid air cells have got two groups, anterior and posterior. Anterior and posterior. Anterior ethmoid air cells are 2 to 8 in number. Posterior 1 to 8 in number. Posterior 1 to 8 number. These two anterior ethmoid air cells are constant cells. Constant cell. Let us give name to them. The name of two constant anterior ethmoid air cells are the bulla ethmoidalis and agar nesi. Bulla ethmoidalis and agar nesi. Agar nesi. Bulla ethmoidalis, which is there in everyone. B for bulla, B for biggest. B for bulla, B for biggest. Biggest. B for bulla, B for biggest. A for agar nesi, A for anterior-most. Anterior-most. So let's revise once again. Anterior ethmoid air cells are 2 to 8 in number. Two cells are constant. Everybody has it. What are the name of these two cells? Number one cell is bulla ethmoidalis. B for bulla, B for biggest. What is the definition of bulla ethmoidalis? It is the largest and most constant anterior ethmoid air cell. What is agar nesi? A-G-G-E-R. Agar nesi is anterior-most anterior ethmoid air cell. A for agar, A for anterior-most anterior ethmoid air cell. Now, these are constant cells. But in some people, there can be anatomical variation and they can have some unusual cell of ethmoid at unusual location. There can be three unusual locations. There can be three unusual locations. So in some people, ethmoid air cells can grow at three unusual locations. What are these three unusual locations? One is the orbital floor. The ethmoid air cell can grow in the orbital floor and then they are called Heller cell. Then they're called what? Heller cell. They can grow close to optic nerve. Optic nerve. Then they're called Ono-D cell. Ono-D cell. And they can grow inside middle turbinate. They can grow inside middle turbinate. If they grow inside middle turbinate, they are called concha bullosa. They are called what? Concha bullosa. Concha bullosa. Am I clear? So, two ethmoid air cells are constant. Bulla ethmoidalis, agar nesi, everybody has. But in some people, there can be unusual ethmoid air cell at unusual location. If these unusual cells form in the orbital floor, they're called Heller cell. If they form in close to optic nerve, they're called Ono-D cell. If they form inside middle turbinate, they're called concha bullosa. Ono-D, O for optic, N for nerve. Okay, easy to remember. Ono-D, O-N, optic nerve. Okay. Now let us see some cells. Bulla ethmoidalis. Guys, let us label together. This is O for orbit, M for maxillary sinus. Between the two orbit, this is the ethmoid bone area. And you can see EB. What is the EB? Largest cell of ethmoid, and that is bulla ethmoidalis. Bulla ethmoidalis. Number two, Agarnes eye. Now, Agarnes eye can only be seen in the axial CT, axial CT, which is like this, because it's the anterior most cell, okay? So this is orbit, and this hole is which bone? Ethmoid bone, full of ethmoid air cell, and the frontmost cell, this one, will be Agarnes eye. Agarnes eye is most anterior. Of course, it can be seen only axial CT like this. So frontmost cell, anterior most cell is Agarnes eye. Now, please see here concha bullosa. Again, orbit, maxillary sinus, IT, inferior turbinate, and of course, this is middle turbinate, and in that, this cell, which is, I put a star over there, this is concha bullosa. A cell is there within the middle turbinate, and that is called concha bullosa. Let me remove the marking for you. Now you see the star over there. Can you see? In the middle turbinate, can you see a hollow cell over there? That is the concha bullosa. Okay? CT scan, sinuses, X-rays are very important for your exam. Hello cell in the orbital floor. And my dear friend, you can see over there, orbit, and this cell is below or in the floor of the orbit. And of course, this is the Heller cell. Okay? Trust yourself. You're very intelligent people. You're smart chaps. And go to the exam with the confidence, with the clarity, and with the hope in the heart that you will really excel in the examination. Because trust yourself. That's very important. Okay. Kalman syndrome. Again, very commonly asked in gynecology also. Please do revise in gynecology this part also. This is a combination of anosmia. There is a smell problem. Patient cannot smell anything. Plus infertility due to hypogonadism. I'm telling you, it's important for gynae also. Please see from gynecology also. So, smell problem with fertility problem, anosmia with hypogonadism is Kalman syndrome. Kalman syndrome. Okay. A patient of anosmia cannot smell ammonia because ammonia is not a smell. Ammonia is an irritant, and ammonia is sensed through which nerve? Ammonia is sensed through which nerve? Trigeminal nerve. Very good. Okay. Fine. A patient of anosmia can still sense which agent? Ammonia. Ammonia is not a smell. Ammonia is an irritant. It is sensed through trigeminal nerve. Test of olfaction. Upset. The best test of olfaction nowadays is University of Pennsylvania smell identification test. University of Pennsylvania smell identification test is the best test of olfaction nowadays. Guys, don't forget the saccharine test. The saccharine test is not for the smell, that is for the motility of the cilia of the nose. Saccharine test. Saccharine test is not for smell. Saccharine test is not for taste also. Saccharine test is for the ciliary motility of the nose area. Okay, but don't forget upset. Upset is for the olfaction, smell. This is the best test of olfaction nowadays. Septal hematoma, always a history of trauma. First of all, patient has fallen down, somebody hit the nose, child was cycling in the ground, he fell down. There will be some history to really start this question first of all. And septal hematoma is bilateral. Can you see both sides? There's a hematoma over there. The treatment of septal hematoma is aspiration or drainage. Otherwise, it will convert to septal perforation. So, septal hematoma history will be of trauma followed by swelling of the nose and bilateral nasal blockage. Okay, trauma to the nose can cause two things: fracture of the nose. Fracture of nose will be given hint by deformity of the nose. But in septal hematoma, no deformity of the nose. In septal hematoma, there will be trauma followed by bilateral nasal blockage. So trauma of the nose followed by nasal deformity, think of fracture of the nasal bone. Trauma of the nose followed by bilateral nasal blockage, think of septal hematoma. It's a bilateral entity. Treatment is immediate aspiration or drainage. Otherwise, it will convert to septal perforation in the future. Okay. Now, septal perforation. What are the questions to be remembered? Most of diseases cause perforation of cartilaginous part of septum, but tertiary syphilis causes perforation of bony part of septum. Tertiary syphilis causes perforation of bony part of septum. Tertiary syphilis can cause two things in the nose. Number one, saddle nose. Number two, the perforation of the bony part of the septum. Guys, please don't forget vaginal granulomatosis. Now, vaginal granulomatosis can cause perforation of both cartilaginous and bony part of septum. The second thing can be epistaxis will be there. Number three will be symptoms of sinusitis will be there. And along with this, hemoptysis will be given in the picture. Vaginal granulomatosis as an autoimmune disorder in ENT is very important. Vaginal granulomatosis, the commonest presentation of this patient in ENT would be sinusitis kind of symptoms. Nasal features are perforation of the cartilage and bony part of septum, epistaxis, and systemic feature will be hemoptysis. Don't forget, this is a possible question of the, the integrated question actually of ENT with medicine actually. Okay, now, what you use to seal the septal perforation? The surgical closure of perforation of the septum is done by septal button. This can be visual question. Please look at the septal button. Keep in mind, septal buttons are used for the surgical closure of the septal perforations. Samter triad, nobody should forget it, but a Samter triad, very important. There'll be history of patient who is actually having nasal polypi, nasal blockage, and there'll be precipitation of asthma-like symptoms upon taking some NSAID like aspirin. That kind of clinical scenario will be created. Samter triad, let's say it's a triad of allergy to aspirin or any other NSAID. There will be nasal polypi both sides, and it is bronchial asthma over there. Guys, it is not extrinsic asthma, beta. There's no exposure to pollen or anything over there. This is not extrinsic asthma, beta. And there is no histamine kind of mechanism also over there. It's more a prostaglandin kind of thing. Please read it from the pulmonology in medicine also. It's a very important topic, beta. Okay, fine. There's no extrinsic asthma in this case. There's no histamine release kind of phenomenon. There's more a prostaglandin thing over there. Keep in mind, beta. It's important. Okay, now. Again, very important topic. Allergic fungal rhinosinusitis. This AFRS, this fungal infection is seen in immunocompetent patients. And not immunocompetent, anybody can get it. And it's a type 1 type of hypersensitivity reaction. Okay. Now, in AFRS, what you see, the two clinical findings. Number one, the typical allergic mucin in the nose, which is very thick, which is like resinous, which is like peanut butter. If you see under microscopy this mucin, you will see fungal hyphae. You will see eosinophils. You will see Charcot-Leyden crystals over there also. And the nasal polypi also very typical. These nasal polypi, if you see, the nasal polypi have got fungal debris into it. So if you do CT scan of this nasal polyp of the fungal patient, you will not see homogeneous appearance. You will see typical heterogeneous or double density shadows on the CT scan. Can you see the CT scan showing? Please see over here, please see, you can see very clearly. This is more dense than this one. There are two types of shadow of the polyp. The fungal polypi contain the fungal debris also. That is why not homogeneous opacities, it's heterogeneous or double density shadows on CT scan. And this is typical of allergic fungal rhinosinusitis. And please keep this in mind. Okay, there's Bent and Kuhn criteria has been asked in a paper. Which of the following is not the major criteria? The major criteria are important. There should be type 1 hypersensitivity reaction. Yes. I told you it's type 1 hypersensitivity. Yes. Nasal polyp. Yes. Typical CT finding. Yes. Eosinophils in the mucus. Yes. And fungal hyphae on the staining. Yes. But culture is not really. Fungal culture is not a major criteria. Fungal culture is a minor criteria. They ask you this question, which of the following is not the major criteria of Bent and Kuhn to classify the patient as AFRS patient? Fungal culture is not a major criteria. You just should be able to see the fungus on the staining. Proving it on the culture is not a major criteria to prove it to a case of AFRS on the Bent and Kuhn system. Actually. Okay, now. Mucormycosis, everybody knows, very important. Mucormycosis is a life-threatening disease. It is seen in mostly immunocompromised patients, and you will be seeing patient profile in the question. Generally, young diabetic patient with the ketoacidosis background, HIV positive patient on immunosuppressive drugs, patient on steroid therapy, but COVID-19 patient, all these will be given. Okay. Now, mucor, a lot of people think mucor will give black color only. No, black color comes, yes, agree, clinical black color. But in the initial few days, only simple reddish, tissues are there. It's just like any other infection. So the early features are different. Please keep it. Early features are different. Yeah, the cheek swelling, redness over the cheek, pain over the cheek, and then the eye swelling is there, blurring of vision will be there, loose upper teeth will be there. That's very important. This area is full of fungus now. As days proceed, this is an angioinvasive fungus. It blocks the blood vessel, causes ischemia, necrosis. Via the blood vessel, it goes to orbit and brain. Therefore, after a few days, the black color will come. The late feature will be black color, like blackish nasal mass, blackish discoloration around the eye, and the brain involvement is also there. Okay, but don't forget, every mucormycosis patient will have black color only. You think early patients can have the normal type of inflammatory picture only. Okay, now what is the best investigation for this patient? not the QI smear, not like endoscopy. The best thing would be radiology. You should go for the contrast MRI of the sinus with the orbit, and you will see the black turbinate sign. Please see, can you see black turbinate sign over there? The normal turbinate is, absolutely okay, but the disease site turbinate is black. Why? Because mucor is angio-invasive fungus. It causes ischemic necrosis, and that shows the black turbinate sign over there. What is the treatment plan? Number one is debridement. It's a dead tissue over there. Ischemia, necrosis, dead tissue to be debrided first of all. And number two, drug of choice is liposomal amphotericin B is the drug of choice. Liposomal amphotericin B is the drug of choice for this patient. Okay, don't forget debridement also. Both of things should do together. But yes, drug of choice is liposomal amphotericin B. And in the last segment, blood supply of the nose comes from two systems. The 80% of circulation comes from external carotid artery, 20% comes from internal carotid artery. What is the demarcation of these two systems? Please see, the demarcation is middle turbinate. Above the middle turbinate is IC area, below the middle turbinate is the EC area. Okay, fine. What are the arteries of the EC? Very simple. Below the nose is what? Lip, palate, palate. From the upper lip comes the superior labial artery, from the palate, greater palatine and sphenopalatine artery. Okay, let's revise. What are three arteries of ECA? Superior labial, greater palatine, sphenopalatine. And from the ICA, two arteries come down with it. What are two arteries? Anterior ethmoidal and posterior ethmoidal artery. Anterior ethmoidal and posterior ethmoidal artery. Why? Between the two orbit, which bone is there? Ethmoid bones. What is the name of artery? Ethmoidal artery. Anterior ethmoidal, posterior ethmoidal artery. But please don't forget, this is 80% of the circulation, major circulation. This is only 20% circulation, and this is above the level of middle turbinate. Now, which is the artery of epistaxis, my dear friends? Majority of time, the bleeding is from sphenopalatine artery branches. The artery of epistaxis is sphenopalatine artery. Okay. Now, epistaxis, main points to remember. Most common area of epistaxis is little area. What is the area? Little area. And little area contains what? Little area contains a vascular plexus called Kieselbach plexus, which is made by four arteries. Let's remember four arteries. Number one, sphenopalatine, greater palatine, superior labial, and anterior ethmoidal artery. So the name of area is little area. It contains which plexus? Kieselbach plexus. It is made by which arteries? Four arteries: sphenopalatine, greater palatine, superior labial, and anterior ethmoidal arteries. Okay. Now, don't forget this picture, beta. For the packings, we use conventional. This is the conventional anterior nasal packing. Okay, with the ribbon gauze. But don't forget this blue picture, beta. This is the new one, PVA packs, beta. PVA packs, you should know as a graduate also that polyvinyl acetate packs, also trade name is Marosil packs. We put in the nose and this gets swollen, they give pressure. So what is the alternative to this nowadays is the conventional pack. Alternative is what? Marosil or PVA nasal packs. This is posterior nasal pack. When you put the pack right behind the nose, how would you see the posterior pack? Please see posterior pack over there. That's the posterior pack over there. Please see, it has got three threads. Three threads. The one thread, second thread, and third thread. So any pack with three threads is posterior nasal pack. Okay, fine. Now the question is, if both packings fail to control the bleeding, you did anterior packing, you did posterior packing, and they are unable to control the bleeding, then the further treatment plan is endoscopic sphenopalatine artery ligation. The further treatment plan is endoscopic sphenopalatine artery ligation. I told you the artery of epistaxis is sphenopalatine artery, and if both packings fail, then you should go for ESPAL, endoscopic sphenopalatine artery ligation. Now, one more question, if ECA ligation fails to control bleeding, you tied the ECA. I told you 20% circulation comes from the ICA. Then the further treatment plan is ethmoidal artery ligation. Ethmoidal artery ligation. Because if ECA has been ligated, still bleeding is continuing, then bleeding is coming from ICA territory, and the ICA branches are ethmoidal artery. We can't tie the ICA with it. Okay, fine, of course. And if source of bleeding is from above the level middle turbinate, you do an endoscopy, the bleeding source is from a level in the nose above the middle turbinate, then it has to be from the ICA system. Then the treatment plan would be again ethmoidal artery ligation. Are getting more clinical question of applied anatomy, beta. If both packings fail, ESPAL to be done. If ECA ligation fails, Then what is the next plan of management? Ethmoidal artery ligation. If the source of bleeding on endoscopy is seen to be an area above the middle turbinate, then of course ethmoidal artery ligation. Okay. So these were the few concepts of the, to be revised, important concept, high yield concept for the nose and sinuses. Hello, my dear friends. Let us start the revision of important points for larynx topic for the examination. First of all, the cartilaginous design of the larynx. And please see over here, this is the thyroid cartilage, which is making the outer framework of the larynx. It's open book-like cartilage. This is E for epiglottis, which is there to cover the vocal cords. And these are vocal cord, of course. And A for arytenoid. Arytenoid is a paired cartilage, and arytenoids make posterior 1/3 of the vocal cord. And C is cricoid cartilage. Cricoid is the complete ring-like cartilage. Which cartilage does not ossify with age? Answer is epiglottis. Okay. Now, this is the real endoscopy picture of the vocal cord. And if you see, this A is arytenoid. These laddus, these big, things are what? Arytenoids, and they make the posterior 1/3 of vocal cord. Next concept is mucosa of the larynx. Once again, see this endoscopy picture of the larynx. The whole larynx is pink in color, but vocal cords are white in color. This will remind me for the exam. The larynx is lined by ciliated columnar epithelium, except vocal cords, which are white in color. So vocal cords are lined by stratified squamous epithelium. Okay. Now, let us talk about a disease which is seen in smokers, and the disease is called, keratosis larynx. Basically, what happens in smokers, the vocal cord epithelium starts shedding faster, and that lead to this keratinaceous debris kind of picture on the vocal cord, which you can see beautifully over here. Now, it's a pre-malignant disease, so patient has to undergo surgery. The surgery is called stripping of vocal cord mucosa or decortication. Also, quit smoking. The newer treatment, the other alternate treatment for this disease is CO2 laser cordectomy. Okay. Now, about vocal cord, what is ring case space, my dear friend? As we talked about, the vocal cord is lined by stratified squamous epithelium. Below the stratified squamous epithelium, we have a loose tissue, the submucosal loose connective tissue in the vocal cord. This is called ring case space. So ring case space is what? Submucosal loose connective tissue layer in the vocal cord. Edema of the space is called ring case edema. Very famous question now. Ring case edema is actually bilateral diffuse swelling of the vocal cord. It is more commonly seen in smokers. The most common cause is smoking, and it's a bilateral entity. Both cords are uniformly swollen, and it would also need surgery. And the surgery is same as the keratosis larynx, and the name of surgery is stripping of vocal cord mucosa or decortication. Okay. Now, so guys, let us start the discussion of next very important clinical topic of vocal nodules, also called as singer's nodule or teacher's nodule or screamer's nodule. The main cause behind it is vocal abuse, and the second common cause is laryngopharyngeal reflux of the gastric acid. And bilateral nodule always, vocal nodule are unilateral, bilateral, always bilateral. What is the site of vocal nodule? Junction of anterior 1/3 with posterior 2/3. So please see junction of anterior 1/3 and posterior 2/3, and they are bilateral nodules. Both sides, this side also, this side also. The chief complaint will be hoarse voice. Generally, history of vocal abuse is there, or reflux of the acid is there in the history of the patient. So, how would you treat it? Treatment is not surgical primarily. Treatment is voice rest or speech therapy plus minus proton pump inhibitor. Plus minus proton pump inhibitor. Okay. So don't mark surgery for the primary treatment of vocal nodule. Go for voice rest choice or speech therapy along with proton pump inhibitor also may be given in the choice. So be careful. Now, let us talk about another disease of vocal cord, intubation granuloma. Intubation granuloma, and it is due to faulty intubation or prolonged intubation in ICU patients particularly. And intubation granuloma is also a bilateral disease. It's also a bilateral disease. Can you see both sides? Okay. The site is junction of anterior 2/3 and posterior 1/3 of vocal cord. Please don't forget vocal nodule was junction of anterior 1/3 and posterior 2/3. Intubation granuloma is junction of anterior 2/3 and posterior 1/3 of the vocal cord. In this case, the treatment will be surgical. The treatment will be microlaryngeal surgery. Okay. So the patient will be, having a history of some surgery undergone under general anesthesia a couple of weeks back, and general anesthesia needs intubation. And after that surgery, after a few weeks, patient has developed change in the voice, and think about intubation granuloma in such scenario, or in ICU patient because of prolonged intubation, the clinical scenario may be created. Now, again, juvenile papilloma of larynx. Now, this is a disease of younger children, juvenile, 3 to 6-year-old child, and this is caused by human papillomavirus 6 and 11. And you can see multiple warty papillomatous lesion on the vocal cord. Okay, now it's a pre-malignant disease, my dear friend. HPV, this is also pre-malignant disease, and these papilloma, these warts can also grow into trachea and bronchi, and the patient would be having chronic hoarseness of voice, and there may be respiratory difficulty also, and the treatment will be carbon dioxide laser surgery, CO2 laser surgery. So you do MLS, microlaser surgery with which laser? Carbon dioxide laser, but recurrence is a big problem in this patient. Don't forget, carbon dioxide laser is used to evaporate these papillomas, but they can come back. The patient might need multiple surgeries. Now, a very famous question is, what are the agents used to decrease the recurrence rate of the juvenile papilloma of the larynx? Please don't forget, intralesional cidofovir is a famous question of the paper. So intralesional injection of the cidofovir is used to prevent the recurrence or decrease the recurrence rate of juvenile papilloma of the larynx. Second one is interferon alpha 2A and bevacizumab. Mainly, please don't forget cidofovir. Okay, fine. Now, supraglottis. Guys, this is a high yield rapid revision of ENT. Okay, supraglottis talk about now. Please see. Now, this is of course your epiglottis. This is epiglottis. This is your true vocal cord, and these are the false vocal cord. True vocal cord and false vocal cord over there. They are pinkish in color. False vocal cord are rudimentary. They don't have any value. Okay. True vocal cord, the real vocal cord are white in color. False, we produce sound from the true vocal cord. But if a patient produces sound from false vocal cord, the disease is called dysphonia plica ventricularis. The other name of false vocal cord is ventricular bands. They are rudimentary, but if a patient produces sound from false vocal cord, it's a disease called dysphonia plica ventricularis. Now, what is ventricle? Please see, this is your false vocal cord, the smaller one. Okay, this is your true vocal cord. Okay, so this is your FVC, false vocal cord. This is your TVC, true vocal cord, and then the V. This is V. V is ventricle. So what is ventricle? It is space between the true vocal cord and the false vocal cord. Okay, my dear friend. Don't forget this saccule. Very famous question, saccule. Saccule is a mucosal outpouching from ventricle. Everybody has got saccule. Saccule is a small mucosal outpouching from ventricle. Now, if saccule become big in size, look at this one. Saccule became big in size, the disease is called laryngocele. So saccule is a normal structure, but if saccule become over distended, to make a disease called laryngocele. Now, laryngocele is common in trumpet blower or bagpiper blower or people who use wind instruments actually. Now, the history will be a trumpet blower or a saxophone player, something like that. And that patient has developed a neck swelling. Now, this is the neck swelling in the patient. Okay, fine. So basically the saccule has got like bigger and it's herniating out. And this is the, of course, the disease is very clear, laryngocele over there. If you press it, the sound of air leak can be heard, and this is called Bryce's sign. So when you press the laryngocele, it is air-filled swelling of the neck. If you press it, what will happen? There will be sound of air leak heard, and that sign is called Bryce's sign over there. Now, we do X-ray of the neck to diagnose it with Valsalva. You close your nose and to try to build up the pressure of air. It will make the swelling more prominent, and this is of course very clearly visible over here. This is the air-filled neck swelling over there. And treatment is surgery. Okay, now. Laryngomalacia, very famous disease. Laryngomalacia is the most common congenital anomaly of the larynx. It is the most common cause of neonatal stridor. It is also called as congenital neonatal stridor. Okay, or congenital laryngeal stridor. Okay, now this is a weakness of supraglottis, and the famous clinical picture on endoscopy shows omega-shaped epiglottis. And in this patient, the chief complaint is stridor, and the stridor has got 4 points to remember. Number one, the stridor is almost since birth. The mother will say, this stridor sound, the noisy breathing sound, started in the first week of life. It increases on crying. Remember, it decreases in prone position. Okay, it decreases in prone position. Okay, and it is inspiratory stridor. Guys, don't forget our class discussion also that these supraglottic problems cause inspiratory stridor. Okay, so stridor is since birth, increases on crying, is less in the prone position, and is inspiratory stridor, and this is indicative of laryngomalacia. Guys, laryngomalacia, the cry sound is normal because vocal cord are normal. Laryngomalacia is the weakness supraglottis. Vocal cord are normal, so cry sound is normal. Read the MCQ very carefully. Okay, what is the treatment of laryngomalacia? Treatment of laryngomalacia is conservative treatment, reassurance to the parents that it is self-limiting disease. Okay, now just for your kind information, conservative treatment can be the treatment of choice in 4 scenarios in ENT. Number 1 is of course laryngomalacia. Number 2 is Number 1 is laryngomalacia. Okay. Number 2 is unilateral vocal cord palsy. Single side cord palsy are managed conservatively to begin with. Number 3, CSF rhinorrhea. Don't go for surgery immediately. If you remember, CSF leaks can stop on their own also. And number 4 is the traumatic rupture or traumatic perforation of the eardrum. Traumatic perforation of the eardrum. Okay, so let's revise. What are the 4 scenarios in which you mark conservative treatment, non-surgical treatment as the primary modality of treatment? Number 1, laryngomalacia. Number 2, unilateral vocal palsy. Number 3, CSF rhinorrhea. And number 4, traumatic perforation of the tympanic membrane. Now, next congenital disorder is congenital subglottic stenosis. Congenital subglottic stenosis. Okay, now please see on this side also. Please see in this side, if you see right behind my picture, please see over here, this is the normal side. But here you see, can you see? The subglottic area has got only small opening, and this is a case of congenital subglottic stenosis. Okay. Now, for this, we use a very famous system of grading. It's called Cotton-Meyer grading of congenital subglottic stenosis. Now, Cotton-Meyer grading has got 4 grades. Grade 1 is 0 to 50% obstruction. Grade 2 is 51 to 70% obstruction. Okay, grade 3 is 71 to 99% obstruction, and grade 4 is no lumen detectable. On CT scan we grade it. Okay, grade 1 is not much symptomatic. So grade 1 treatment is conservative treatment. Conservative treatment. Okay, now grade 2 would need treatment. You will need laser treatment, or you will need dilatation, and you need to apply the mitomycin C. After you dilate it with the dilators, you apply which drug? Mitomycin C. Mitomycin C. Okay. And grade 3, grade 4 will need, grade 3 and grade 4 will need proper surgery called laryngotracheal reconstruction, followed by the placement of a special tube called Montgomery's silicone tracheal T tube. Montgomery's silicone tracheal T tube. Montgomery's silicone tracheal T tube. Now, this is a visual question of the paper. This is used in the management of laryngotracheal stenosis, and it's placed for a few days to support the graft you have created over there. Guys, mitomycin C is a very favorite topic of the examiners. Mitomycin C is actually having anti-fibroblastic properties. It is topically applied, and it can come in different multiple choice questions. Number 1, in the management of laryngotracheal stenosis, as we discussed just now. Number 2, it can be used to prevent the formation of synecdoche in the nose after surgery. Number 3, it can also be used in the surgical management of choanal atresia. Okay, so number 1 is mitomycin C, laryngotracheal stenosis. Number 2 is, of course, preventing the formation of synecdoche in the nose after surgery. And number 3, choanal atresia management. So 3 questions over there. Now, pediatric laryngeal infections, very, very important about ENT and pediatric, both acute epiglottitis. It is more commonly seen in 2 to 7 year age of children, and there's a lot of edema in the larynx. It's a bacterial infection. The most common bacteria nowadays is Streptococcus pneumoniae. Second common is Haemophilus influenzae B. Now, this patient will be having inspiratory stridor. A supraglottic problem causes inspiratory stridor. Number 2, it's a very sick child. There is a very severe respiratory difficulty in the child. Look at the multiple choice question scenario, and the patient will be having drooling of saliva, hot potato voice, the child will be sitting, bending forward, and that is called tripod sign. Tripod sign. Okay. And please don't forget the X-ray of this patient. X-ray soft tissue neck lateral view in this patient will be showing thumb sign. Thumb sign. Now, what is the number one treatment of epiglottitis? So, epiglottitis is a very serious pediatric airway emergency. In this patient, you should immediately go for airway management. Airway management by intubation is the primary management of this patient. Number two, please keep in mind, avoid repeated laryngoscopy, because repeated laryngoscopy can lead to more edema of the larynx. Basically, there's edema of the larynx. Don't do laryngoscopy again and again. It will actually lead to more edema of the larynx. Now, you should give steroids and you must start the antibiotics also. But the primary treatment is airway management. Now let's have a second disease of pediatric laryngeal infection. The name of the disease is acute laryngotracheal bronchitis, or ALTB, or croup. Now this is a viral infection of the airway. It's caused by para-influenza virus, and the age group is 3 months to 3 years. Now this patient will be having mild respiratory difficulty. There will be stridor, but the important thing is there will be barking cough. Don't forget, laryngotracheal bronchitis will lead to bronchospasm, and the bronchospasm will lead to barking cough in this patient. Okay. Now don't forget the X-ray. X-ray of ALTB patient will show which sign? Steeple sign. And steeple sign is what? Narrowing of the subglottic area. Guys, in laryngotracheal bronchitis, the whole airway is infected, but the most affected area is subglottis. And if you remember, the most narrow part of the pediatric larynx is subglottis. So subglottis get even more narrow. This is the narrowing of the subglottic area over here. Please see over there. This is your trachea, which is pretty okay. But if you see closely, the subglottic area get very narrow. This is like a steeple of the church. Okay, steeple sign. Now, okay, the treatment of ALTB, generally patient is not that sick. Epiglottitis baby is more sick. This patient will be needing mostly humidified oxygen, bronchodilator, steroids, and antibiotic to prevent secondary bacterial infection. I repeat, the patient will be needing humidified oxygen, number 2, bronchodilator, number 3, steroids, and antibiotic to prevent secondary bacterial infection. Now, very important topic, cancer larynx. Everybody's scared of this topic. Cancer larynx staging mostly is asked. Okay. Now, let us simplify staging. T1. Only one named structure involved. Tumor involving epiglottis is T1. You can ask me, Rajiv, what about vocal cord? If one vocal cord is involved, it is T1A. Okay. T1A means one vocal cord involved. T1B means both vocal cord involved. Okay. Till the time one named structure is involved, it is actually the T1. Tumor involving, airy epiglottic fold only, T1. But what about vocal cord? The name is vocal cord only. So one vocal cord involved, two vocal cord involved, name is still vocal cord. So one cord involved, T1A, both cord involved, T1B. Now, T2, more than one named structure involved. Moment MCQ says tumor involving epiglottis, airy epiglottic fold. Two different structures are being mentioned in the multiple choice question. It is T2, T2. Okay. Now, T3. The most important thing to remember about T3 is the vocal cord is immobile or fixed. Vocal cord is immobile or fixed. Okay. The fixed vocal cord or immobile vocal cord is T3. Guys, impaired vocal cord mobility is T2 only. T2. Vocal cord has to be fixed or immobile to classify it as T3. If the MCQ says about the impaired cord mobility, normal cord mobility, it is T1 or T2. Okay. Guys, impaired cord mobility is also T2 only. Okay. So to call it T3, it has to be fixed or immobile vocal cord. Or there may be invasion of some space like pre-epiglottic space or paraglottic space. There may be invasion of pre-epiglottic space or paraglottic space. Okay. If the MCQ mentioned about some space involvement in CT scan, that is absolutely the T3. T4, very important question. Invasion of thyroid cartilage or extra laryngeal extension into neck structures, for example, into the thyroid gland. Okay, are you getting my point? T4 means invasion of thyroid cartilage or extra laryngeal extension into neck structure like thyroid gland. So that is T4. Now this is the CT scan. This is a very commonly asked question also. In the CT scan, this is T4. T4. Why it is T4? Please understand over here. Please see, this is the thyroid cartilage invasion. Can you see over there? Can you see over there? The tumor has invaded thyroid cartilage, is trying to go extralaryngeal. This is actually the T4 stage of the laryngeal cancer. Okay, fine. Now let us discuss the treatment of this patient of cancer larynx. Treatment of T1 will be radiotherapy. But nowadays, recent advances for T1 glottic cancer, the treatment of choice is CO2 laser surgery as the number one therapy. The second option in that case is radiotherapy. Overall treatment of T1 cancers of laryngeal malignancies is radiotherapy. T1 is radiotherapy, but nowadays, because of laser getting more and more popular, for T1 glottic cancer, vocal cord cancer, if the question asks you, particularly glottic cancer, vocal cord cancer, if they ask you T1, then you please mark the CO2 laser or laser chordectomy as the primary modality of treatment, better therapy than the radiotherapy. Okay, now T2, radiotherapy. But second option in this patient is partial laryngectomy if lung functions are normal. Partial laryngectomy if lung functions are normal, but the primary modality will remain radiotherapy. Second is the horizontal or vertical partial laryngectomies, provided the lung function normal, but this is a second option if radiotherapy is not given in the choice. T3, T4, bigger tumor, bigger treatments, total laryngectomy along with radical neck dissection if required, followed by radiotherapy. So T3, T4, there may be neck node metastasis in that case. T3, T4 will be requiring total laryngectomy plus minus radical neck dissection followed by radiotherapy. What is the second option in a patient of T3, T4? In T3, T4, the second option is concurrent chemoradiation. The second option is concurrent chemoradiation. T3, T4, the second best option will be concurrent chemoradiation. Let's revise once again. T1 is one structure involved. T2 is more than one structure involved. T3 means vocal cord fixed, or there is immobility of vocal cord or some space involvement is mentioned. T4 is thyroid cartilage invasion is there or extra laryngeal extension into neck structure is mentioned. T1, T2 radiotherapy. But T1 nowadays, for T1 glottic cancer, we should mark CO2 laser surgery as the number one choice. For T2, radiotherapy is there, but alternate treatment, second best option for T2 is partial laryngectomies. For T3, T4, definitely total laryngectomy with radiotherapy, but second best option is concurrent chemoradiation. Now for T3, T4, after laryngectomy, when you do, patient develop permanent tracheostomy and the patient cannot speak. There's a permanent hole in the neck. Now these patients can use esophageal voice to speak. Number two, they can use the electrolarynx or artificial larynx. Now this is a handheld battery operated external mechanical vibrator. Okay, handheld battery operated external mechanical vibrator. Patient has to touch it over here to speak. The best option to speak after laryngectomy is tracheoesophageal puncture device, TEP device. It is actually the unidirectional valve which is surgically placed between trachea and esophagus. Now this is a famous question. If you ever see a plastic nipple like thing on the posterior wall of trachea through the tracheostomy hole, it is a tracheoesophageal puncture device. And the more common example of TP device is Blom Singer prosthesis, or number two, you can use this, of course, Provokes prosthesis nowadays. Okay, now sensory nostril larynx is getting very popular now. Now, supraglottic area, it is supplied by internal branch of superior laryngeal nerve, also called as internal laryngeal nerve. Okay, internal branch of superior laryngeal nerve is a very important thing, beta. It is also called as internal laryngeal nerve that gives sensory supply to supraglottis. The subglottis is supplied by recurrent laryngeal nerve, and glottis is supplied by both these nerves. Vocal cord. Glottis means vocal cord. Once again, supraglottis sensory supply comes from internal branch of superior laryngeal nerve, also called as internal laryngeal nerve. Subglottic area, the sensory supply is recurrent laryngeal nerve, and subglottis area, the sensory supply comes from both these nerves. Now, after sensory supply, let us talk about the motor supply of the larynx. So guys, the larynx has got many muscles. One muscle lies outside larynx. What is that muscle? Cricothyroid. So guys, all muscle of larynx lies inside larynx except cricothyroid. Therefore, all muscle of larynx are supplied by recurrent laryngeal nerve except cricothyroid. So cricothyroid is supplied by what? It's lying outside larynx. So let's complete the statement. All muscle larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Let's revise one more time. Which muscle lies outside larynx? Is the cricothyroid. Now, therefore, all muscle of larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external branch of superior laryngeal nerve. Now, look at this picture. RLN, SLN are two main nerves of the larynx. They are branches of vagus nerve. Now, guys, the recurrent laryngeal nerve. Please see, the recurrent laryngeal nerve. Please see over here. Recurrent means it recurs its course. Recurs its course. Right side takes a turn around the subclavian artery. It has got a shorter course. And left side takes a turn around the arch of aorta. Left side takes a turn around the arch of aorta. Okay. This is right side takes a turn around subclavian artery. Left side takes a turn around arch of aorta. Since left RLN got a longer course, therefore chances of left cord paralysis are 4 times more than the right side. Now, what is this gland, beta? What is this gland? Thyroid gland. So thyroid gland has got a very important relation with the laryngeal nerves, beta. Now, please see over here. Now, please see over here. This is your thyroid gland. Okay, this is thyroid gland. Larynx got two important nerves, RLN, SLN. Both are branches of which nerve? Vagus nerve. Recurrent laryngeal nerve and superior laryngeal nerve are the sensory and the motor supply of the larynx, and they both come from the vagus nerve. Now, please see over here, the RLN lies very close to the lower pole of the thyroid gland, and SLN lies very close to the upper pole of thyroid gland, superior laryngeal nerve. So the relation of thyroid gland with the nerves is very important because they can be damaged during the thyroid surgery. Okay. Now, let us do one discussion that if RLN is cut during damaged, both side RLN got damaged, both sides during thyroid surgery. Bilateral RLN injury during thyroid surgery, practical MCQs better. Which muscle is still working? Cricothyroid. Why? Because we just said that all muscle of larynx is supplied by recurrent laryngeal nerve except cricothyroid. Now, what is the function of cricothyroid? It has two functions. It's adductor and tensor also. So basically, for us, it is adductor at the moment. Adductor means it will bring the vocal cord to the midline. So both vocal cord has got only one muscle left working, which is cricothyroid, and unfortunately, it is adductor muscle. Now, please see, this will lead to a situation called bilateral abductor paralysis. Bilateral abductor paralysis means both vocal cord have come in the midline and a permanently closed vocal cord. Guys, the famous golden rule is we breathe with open vocal cord, but we speak with closed vocal cords. Unfortunately, both RLN have got damaged. All muscle were non-functional, only cricothyroid was functional, and that is actually adductor muscle. Both vocal cord came in the midline and stopped over there, and this is a condition called bilateral abductor paralysis. The golden rule is we breathe with open vocal cord, we speak with closed vocal cord, but unfortunately in this situation, vocal cord are permanently closed. So patient cannot breathe but can speak normally. So the chief complaint right after surgery of thyroid is over, patient is being extubated, you will have very serious airway emergency in the operation theater only. Right after extubation of the patient will be having respiratory difficulty and stridor, but voice will be normal. This patient would need immediate treatment, will be tracheostomy to save the patient. How many months we wait for the spontaneous recovery? For 6 months. If 6 months shows no recovery, then what is the treatment of choice of bilateral abductor paralysis? The definite treatment after 6 months of this patient will be type 2 thyroplasty or lateralization of vocal cord, which means that we pull one vocal cord to the side actually to open up the airway. So the treatment of choice of bilateral abductor paralysis is type 2 thyroplasty after 6 months. This is lateralization of vocal cord. Okay, fine. Now, this was bilateral abductor paralysis. Now, let us see another condition called bilateral adductor palsy. Adductor palsy means reverse of bilateral abductor. What happens is when both vagus are damaged. Both vagus are damaged. You know, RLN and SLN are the branches of which nerve? Vagus nerve. If vagus is cut, larynx is dead. Larynx is dead, beta. It means when both vagus are damaged, it is a complete paralysis of the laryngeal innervation. Both RLN, SLN are gone. It means that vocal cord will come in cadaveric position. Cadaveric means when no nerve is working, and the cadaveric position is open position. So this is the case of bilateral adductor paralysis. It's seen in a very rare situation of bilateral vagal paralysis which is the complete paralysis of the vocal cord, which means RLN and SLN both got paralyzed. And when vagus is cut, larynx is dead. So vocal cord come in cadaveric position, and cadaveric position of vocal cord is open vocal cord. And if you remember the famous rule, we breathe with open vocal cord and we speak with closed vocal cord. And this patient has got permanently open vocal cord. So breathing is not a problem, but the main complaint will be aphonia, loss of voice. Patient cannot speak normally. There will be air leak. Problem like that. That's the problem. Okay, aphonia. And number two, aspiration. Beta. Whatever you eat, some part of that will go into your lungs also. If you are eating dosa, the sambar will go into your lungs also, and we can develop the sambar pneumonia also. Beta. Okay, fine. You understand? So pneumonia can happen in this patient, but not a serious emergency. So this patient will be requiring again 6 months wait. After 6 months, if no improvement happen, the definitive treatment of bilateral adductor paralysis is the type 1 thyroplasty. So what is the definite treatment of this patient after 6 months is reverse of the first one. It is type 1 thyroplasty. Type 1 thyroplasty is medialization of vocal cord. Medialization of vocal. Type 2 was lateralization of vocal cord. And type 1 is medialization of vocal cord. So these are 2 thyroplasties. Guys, why not revise all the 4 thyroplasties better? Guys, let us revise all the 4 thyroplasties. Type 1 thyroplasty is medialization of vocal cord done for adductor palsy. How do you remember it? MAD. MAD. People who come first in the class, type 1. People who come first in the class are mad people. People who come first in the class are bad people, you know. Sorry, don't mind. Toppers don't mind it. I'm just trying to create something easy for you to remember. Type 1 is MAD. Type 1 M mane medialization, AD mane adductor paralysis. Type 2 is reverse of the type 1. So type 2 will be lateralization done for abductor paralysis. Okay. And type 3 and type 4 are done for the puberphonia, androphonia. You know, remember, normal voice in male is low pitch voice. Normal voice in female is high pitch voice. But if a male has a high pitch voice like a female, it's called puberphonia. And the name of surgery is type 3 thyroplasty, which is shortening or loosening of vocal cord. Type 4, reverse of type 3. Type 4 is done for androphonia. Androphonia is what? When a female has got a low pitch voice like a male. Okay. And that is, patient is called androphonic patient, and that patient would be needing which surgery? Type 4 thyroplasty. And type 4 thyroplasty is lengthening or tightening of vocal cord. Lengthening or tightening of the vocal cord. Let's revise once again thyroplasties. That's very easy, but type 1 and type 2 are opposite to each other. Type 3 and type 4 are opposite to each other. Type 1 is MAD. Type 1 is medialization done for adductor palsy. Type 2, let's reverse it. Type 2 is lateralization done for abductor palsy. Type 3 for puberphonia, it is actually shortening or loosening of vocal cord. Type 4 is done for androphonia, it is lengthening or tightening of vocal cord. Okay. Now, one more question of vocal cord paralysis. Now, as you know, the thyroid gland has got another nerve at the upper pole, and it is superior laryngeal nerve. Okay. If this gets damaged, what will happen? Which muscle will lose its function? Cricothyroid muscle is gone. Cricothyroid is gone. And I hope you remember, cricothyroid has got two properties, beta, adductor property and tensor property. In fact, cricothyroid is the main tensor of vocal cord. And if you remember, tensors give us quality of the voice. So if SLN is damaged, cricothyroid muscle function will be lost. Patient will be having poor quality of the voice. And of course, there will be aspiration problem also, because the supraglottic sensory supply comes from internal branch of superior laryngeal nerve. So once again, superior laryngeal nerve has got two branches. External branch gives cricothyroid supply and internal branch gives sensory supply to supraglottis. So there will be two problems with the patient. Problem number one will be poor quality of the voice, because the cricothyroid is the main tensor of vocal cord, and tensor determine the quality of the voice. Quality of voice will be poor in this patient, and sensory loss will lead to aspiration issue in the patient. Aspiration issue in the patient. Okay, fine. Let's go further. Let us discuss this visual question possible, Heimlich maneuver. So patient, would be having a history of, having some food, and during eating, patient develops choking and aphonia. And this is a clear-cut case of some aspiration of the food particle in the larynx. It's a case of laryngeal foreign body. And anytime the situation is created like that, The first treatment will be hemorrhage maneuver. Please remember the picture. The pressure is given on the epigastric area in the upward and backward direction. Pressure given in the epigastric area in the upward and backward direction. Okay. So hemorrhage maneuver is used for the laryngeal foreign body, and a typical scenario will be the patient having food and developing aphonia and choking feeling. Hemorrhage maneuver. And don't do this in children. In children, we go for what? The tight back flaps over there. Now, next thing, what is the best tracheostomy tube for an ICU patient or otherwise an adult? It has to be a cuffed tracheostomy tube, and the complete name is Potex PVC cuffed tracheostomy tube. Cuff helps to decrease the aspiration. Cuff doesn't allow the air leak also. So that's the advantage over there. Guys, tracheostomy can lead to complication like hemorrhage. The most common complication will be hemorrhage, of course, but tracheostomy can lead to surgical emphysema also. Now, what is surgical emphysema? It is the collection of air beneath the skin. So it's a collection of air in the subcutaneous plane of the neck, because from the tracheostomy hole, some air will leak and start collecting below the planes of the subcutaneous tissue below the skin, and the collection of air below the skin of the neck of the patient after tracheostomy or after anything is called a surgical emphysema. Now, what question is, what is the cause of surgical emphysema? Tight skin suture. After tracheostomy, we give a cut when over here. Some surgeon apply very tight skin sutures, so there is no way for the air collected below skin to come out. So that's why the cause behind surgical emphysema is the tight skin sutures over there. The other complication which we see right during tracheostomy is apnea. The breathing stops. The reason is the CO2 washout. So why apnea happens? Because suddenly carbon dioxide leaks to the body and the drive for the respiratory centers is gone. So apnea is due to CO2 washout, and surgical emphysema is due to tight skin sutures of the neck. Okay. So these were the various points I wanted to highlight about the concept of the larynx for the exam. So friends, let us start the revision of the important points of the pharynx now. The pharynx has got three parts: nasopharynx, oropharynx, and laryngopharynx. Behind the nose is the nasopharynx area. Right now, you're seeing the picture of nasopharynx. The posterior opening of the nose is called choana, and right behind the choana, you are seeing the nasopharynx. In the nasopharynx, you've got two important landmarks. Well, number one is, of course, the adenoid tissue, which is more prominent in children. This A represents the adenoid tissue, which is a lymphoid tissue, and it's more prominent in children. And of course, this is the eustachian tube opening. And I hope you remember the eustachian tube connects the middle ear to nasopharynx, and this is the middle ear, and that's the eustachian tube, and it's connected to the nasopharynx via eustachian tube, and that's the rough kind of outline towards the design. This ME represents middle ear, and if you remember, like middle ear, produces mucus, and it's a middle ear mucosa is secretory in nature, and this mucus comes via the eustachian tube into the pharynx. Okay, now by chance, the eustachian tube gets blocked, there will be a disease in the middle ear which is called glue ear, because the accumulation of the mucus and the negative pressure in the middle ear. The disease is called glue ear, also called serous otitis media or otitis media with effusion. So nasopharyngeal diseases can cause middle ear diseases. Please do keep in mind, it's a very commonly integrated question asked actually. In which two topics it can be asked in the pharynx and the ear? Please see, this is what the endoscopy picture of the child and the adult is. The first picture is of the child. This is child's picture, and adenoids, they disappear by 20 years of age. This is the normal endoscopy picture of the adult nasopharynx. Okay, now just try to understand, if a child suffers from a disease which is called adenoid hypertrophy. Please see, if adenoid become too big in size, can you imagine? This is a normal adenoid picture, and this adenoid start becoming bigger in size, it will block the eustachian tube opening, and the disease in the middle ear will be called glue ear. Okay, so adenoid hypertrophy causing glue ear is a very common entity to be asked. Similarly, an adult patient developing nasopharyngeal carcinoma, okay, right in the nasopharyngeal area, this can also block the eustachian tube opening. So the story of the glue ear can be asked in two clinical scenarios in the pharynx, Number one is adenoid hypertrophy in school age children, and number two, nasopharyngeal carcinoma in adults. It's a very commonly asked integrated question of these two topics of ear and pharynx. Now, let us first of all discuss the adenoid hypertrophy. Adenoid is a very common problem in children, school age children, particularly 6 years, 7 year age children. Again, you see the first picture represents the normal endoscopic picture of the child. This is the normal adenoid, A for adenoid, normal. This is normal, the child picture, no problem. But this is, of course, adenoid hypertrophy. And you can see the choana is completely blocked, the nose is completely blocked from behind. The child will have a mouth breathing pattern, and the disease will be seen in school age children. The typical look of the child is called adenoid face, and the main thing in that is the mouth breathing. The mouth is always open. The teeth are also having dentition problem, malocclusion of teeth, pinched nose, and the palate is also going high in these children. So remember, adenoid face, mouth breathing child is a clear-cut clue for the adenoid hypertrophy MCQ. And adenoid hypertrophy question will very commonly be asked with the glue ear scenario. So mouth breathing child with the hearing loss is a definite clue towards adenoid hypertrophy with glue ear. I repeat, mouth breathing child with hearing loss problem. Its diagnosis, first of all, number one come to your mind should be the adenoid hypertrophy with glue ear. Patient needs surgery, adenoidectomy under general anesthesia, and when you do a surgery, you have to put the position of the patient, and the position is called rose position, and rose position involves extension of the neck significantly. But don't extend the neck too much during rose position, because if you do overextension of neck, this can lead to very serious complication of atlantoaxial subluxation. The C1, C2 vertebra can get subluxated due to overextension during giving rose position to the patient for the adenotonsillectomy surgery. And this is called Gristle syndrome. My dear friend, please do remember, rose position involves neck extension. The rose position is used for the adenoid surgery also and tonsillectomy also. But overextension of neck should be avoided because this can lead to atlantoaxial subluxation. And this is called Gristle syndrome, guys. This is a very famous question again, Gristle syndrome. Okay, now, nasopharyngeal carcinoma. It's the adult patient. Please see, adenoid hypertrophy, school age children. Nasopharyngeal carcinoma, adult patient. Mostly, this cancer is common in China. However, it is reported in India also. But the main culprit behind this cancer is Epstein-Barr virus. It's proven. Epstein-Barr virus is the proven etiology behind nasopharyngeal carcinoma. What is the site of origin of nasopharyngeal carcinoma? The answer is fossa of Rosenmuller. Now, fossa of Rosenmuller is a visual question also of anatomy in your paper. How to identify it? Please see. This is eustachian tube opening. If they ever put an arrow right above the eustachian tube opening, that area is fossa of Rosenmuller. And I know this is right behind the nose, a very hidden area, very, not easy to examine area. And if by chance cancer develop from this area, it will be quiet, hidden cancer. So it's very unknown kind of primary. And very soon, it will be covering the eustachian tube opening also. So there will be a glue ear on one side in an adult patient. My dear friends, glue ear is mostly a disease of children due to adenoid hypertrophy. No problem. But if an adult patient develops glue ear only on one side, I should have a suspicion in my mind as a clinician that maybe the patient is having a hidden nasopharyngeal carcinoma right behind his nose. Okay? Adult patient. Single-sided glue ear. Think of nasopharyngeal carcinoma. And don't forget fossa Rosenmuller. Now, as I told you, NPC is hidden cancer, means occult primary. Now, cancer is actually developing in this area. How can you see this area? It's very difficult to see unless you do endoscopy. And very soon, this cancer is going to metastasize. The neck nodes will develop metastatic lymphadenopathy. So patient will come to the clinic and without even knowing patient has got cancer, patient will say, doctor, I've got neck swelling. What is this neck swelling? And that's a multiple choice question also. The most common clinical presentation of nasopharyngeal carcinoma is secondary neck node or metastatic cervical lymphadenopathy, and this is a very commonly asked clinical question. How to remember? NPC, nasopharyngeal carcinoma. What is the first letter of the cancer? N. The first symptom is most likely being the N is neck. So the commonest presentation of nasopharyngeal carcinoma will be metastatic cervical lymphadenopathy or secondary neck node, something in the neck. How to memorize? NPC, nasopharyngeal carcinoma. First letter is N. The symptom will also first, N means neck has to be there in the answer. Now, nasopharyngeal carcinoma is a skull-based cancer, so there is a high chance of cranial nerve involvement in this patient. And that cranial nerve involvement gives rise to a triad called Trotter's triad. So Trotter's triad of NPC, nasopharyngeal carcinoma, the good thing is the mnemonic of this is also NPC. What is N? N for neuralgia in temporoparietal area due to fifth nerve involvement, trigeminal nerve involvement. P for palatal palsy due to 10th nerve involvement. And C for conductive hearing loss due to glue ear. Glue ear on one side. All these things are unilateral. I told you, nasopharyngeal carcinoma has got high chance of cranial nerve involvements, and that cranial nerve involvement along with the conductive hearing loss due to glue ear gives a triad called Trotter's triad. It is seen in NPC. That mnemonic is also NPC. N for neuralgia in temporoparietal area due to fifth nerve involvement. P for palatal paralysis due to 10th nerve involvement, and C for conductive hearing loss due to glue ear. And all of these features are unilateral and ipsilateral. Now, the treatment of nasopharyngeal carcinoma will be chemoradiation. You will take a biopsy after doing nasopharyngoscopy, prove it's cancer, and best treatment modality would be chemoradiation. Radiotherapy is the main thing. Nasopharyngeal carcinoma is a radiosensitive tumor, but chemotherapy given along with radiotherapy is more effective. But if by chance you don't see this in the answer, then the answer is radiotherapy only. Pure chemotherapy has no role in this. The best answer is chemoradiation. The second best answer in this question as a treatment modality will be radiotherapy. Let us do the next topic of nasopharynx, and that is juvenile nasopharyngeal angiofibroma. Like nasopharyngeal carcinoma was a malignant entity of the nasopharynx. Juvenile nasopharyngeal angiofibroma, popularly called angiofibroma, it is the most common benign tumor of nasopharynx. NPC was cancer. Angiofibroma is the most common benign tumor of nasopharynx. What is the site of origin of angiofibroma? The answer is sphenopalatine foramen. Now, this is a highly vascular tumor. Look at the word angiofibroma. It is made of blood vessels. This is exclusively seen in adolescent males, boys, young boys, 12 to 16 years. Maybe 18 also, maybe they give it. Okay, but no problem. A younger male would be the only clinical, I would say, candidate for this particular, tumor. So this tumor is exclusive for adolescent males. And so the age profile will be 12 to 16 years generally. And remember, it's a highly vascular tumor. What will be the clinical scenario given the exam? 12 to 14 year, 15 year or 16 year old boy, male patient, of course, with nasal mass, with profuse epistaxis. There's young boy with nasal mass and nasal bleeding is angiofibroma. Don't change the answer, beta. Please go for the common things in the paper. Stick to the common, characteristic of that tumor. Additional finding may be given. They might give you additional finding like cheek swelling, some, ocular issues, some maybe headache, some maybe glue ear, etc. Those are additional things because the tumor will spread and can cause multiple other things. But the key characteristic thing will be young male with nasal mass and profuse epistaxis. It's a benign but locally invasive tumor. It can go into the orbit also. And that will lead to proptosis, and that is called frog face deformity. Now, frog face deformity is typical of angiofibroma. Basically, it depicts the proptosis caused by the orbital extension of the tumor. Please do remember, it's a benign but locally invasive tumor. The tumor can also spread to cheek, and therefore there can be cheek swelling in this patient also. However, the primary symptoms of the patient would be nasal mass, profuse epistaxis, but yes, cheek swelling, ocular features may be given along with it. Guys, don't forget again that it's a highly vascular tumor. It is seen in adolescent boys. Basically, it's a hormone sensitive tumor. Means some androgen dependence is there. Therefore, if you see, to decrease the vascularity of the tumor before surgery, we can give pre-operative either estrogen or flutamide. Remember the word flutamide, it's anti-androgen. These two things will shrink the tumor because surgery is going to have a lot of blood loss. So if you give estrogen before surgery or flutamide, anti-androgen before surgery, it's going to shrink the tumor. It's going to make the surgery little easier. Less blood loss will be encountered in this patient. So don't forget the word flutamide. Okay, pre-operative flutamide to the patient. Biopsy is contraindicated. It's a more of a clinico-radiological diagnosis, and biopsy would not be because it's a highly vascular tumor. Now, CT scan would be, of course, contrast enhanced CT scan. In this case, it's a vascular tumor. So CECT would show Hallman-Miller sign. Now, what is Hallman-Miller sign? Please see, the tumor is growing right behind the maxilla. So the tumor will be pushing the posterior wall of maxilla forward. This is M is maxillary sinus. This is normal side, and this is the disease side. Okay, this red arrow represents the tumor. Okay, can you see the posterior wall of the maxilla on the normal side versus posterior wall of the maxilla on the disease side are at different level. Tumor is pushing the posterior wall of maxilla forward. This anterior bowing of posterior wall of maxilla is technically called Hallman-Miller sign, which is a radiological sign on CCT of angiofibroma. Along with CCT, we always do angiography also preoperatively. Why do we do angiography? To find out the main source of blood supply for angiofibroma, and most common source of blood supply for the angiofibroma is maxillary artery. Maxillary artery, okay? And what shall we do? Pre-operative embolization of this artery will reduce the blood loss during surgery. So angiography, the most common blood supply for the tumor is maxillary artery. What should we do? Pre-operative embolization of maxillary artery will reduce the blood loss during surgery. Treatment of choice of angiofibroma is surgery only. Guys, if the tumor is limited to nasopharynx and nose only, if the MCQ says it's a stage 1 angiofibroma, the tumor is only in the nasopharynx and nose only, the best approach nowadays is endoscopic approach. Okay, but before surgery we do the pre-operative embolization depending on the finding of the angiography. Let us do the next very important topic of pharynx is quinsy or peritonsillar abscess. Peritonsillar, basically there's a collection of pus between the tonsil and its bed. This is the collection of pus between tonsil and its bed, and that pus is pushing everything on the other side. The two clinical findings on examination are: number 1, uvula is pushed to other side. Number 2, tonsil is pushed medially. So it's collection of pus between tonsil and its bed. Therefore, uvula is pushed to other side, tonsil is pushed medially. Guys, please do remember, in quinsy, there is no outer neck swelling. Here, there is nothing over there. Okay? Intraorally, they give you oropharyngeal picture. Uvula angulated, think of quinsy. Only thing, please check in the MCQ, there should be no outer neck swelling. Quinsy does not have outer neck swelling. Okay? Now, so again to revise, what are two classical findings? Uvula is pushed to the other side. Tonsil is pushed medially. But very importantly, there's no outer neck swelling in quinsy. That's very important thing to remember. Okay, what are the clinical presenting feature of this patient? Number 1, trismus will be there. Patient will have difficulty in mouth opening due to spasm of which muscle? Medial pterygoid muscle. Trismus, what is trismus? Difficulty in mouth opening. And what is the cause of trismus? Spasm of which muscle? Medial pterygoid muscle. And number 2, classically hot potato voice or plummy voice or muffled voice. These two features are always there. There will be throat pain, there will be dysphagia. Always remember, in a clinical multiple choice question of medicine, surgery, ENT, everywhere, there will be additional symptom written in addition to the common symptom. Please look for the common symptom first of all. Muffled voice or plummy voice or hot potato voice, trismus is there, and this is quinsy. Okay, but just make sure there's no outer neck swelling. Okay, now this is a quinsy picture. Now in quinsy, I think you are absolutely now clear. Neck is normal. Outside examination neck is normal. There's nothing over there. But if by chance the same MCQ of like quinsy, uvula pushed to other side, tonsil is pushed medially, that is all given over there. Along with that, they give you that there is an outer neck swelling also close to angle of mandible or close to sternocleidomastoid muscle. Then the answer will change to parapharyngeal abscess. These two questions are very overlapping, beta. Please understand, quinsy has got nothing outside in the neck, but if quinsy like MCQ is asked to you, uvula pushed to other side, tonsil pushed medially, trismus is there, hot potato voice, everything is same. Everything is same. Along with that, outer neck swelling close to angle of mandible or close to sternocleidomastoid muscle is given, then the answer is shifted to parapharyngeal abscess. My dear friend, there are two equations in ENT you need to remember. Quinsy plus outer neck swelling is equal to parapharyngeal abscess. In the nose, atrophic rhinitis plus hard external nose is equal to rhinoscleroma. Okay, remember two equation of ENT. Okay, because these two questions look similar, but if you know the fine point, you will be able to crack the answer. The similar word to quinsy, and this is called Quincke's disease. Don't use spellings, this should not be confused with QU. Oh, quinsy. No. Read it carefully. Quincke is something else. This is angioneurotic edema of the uvula. It's angioneurotic edema of the uvula. I will not confuse Quincke with quinsy. Okay, Quincke is something else. Uvular edema, angioneurotic edema of the uvula is called Quincke's disease. Okay, now Ludwig's angina. Ludwig angina is infection of floor of mouth, also called submandibular space infection. And one definition, Ludwig angina is infection of floor of mouth or submandibular space. Now, what the submandibular space means, the chin area. Basically, what please see over here, this is your mandible. This is your what? Mandible area. And in the mandible, we have got molar and premolar. One of the molar or premolar got caries, and from there the infection came to this side. So basically the clinical story will always start with dental infection in this case. So what is the clinical story? Dental infection leading to chin swelling, trismus, and respiratory difficulty may be there. But chin swelling and trismus after dental infection will be Ludwig's angina. My dear friend, parapharyngeal abscess is also commonly due to dental infection. But in parapharyngeal abscess, there is no chin swelling. In parapharyngeal abscess, the swelling is close to angle of mandible. So, two questions after dental infection. Dental infection causing chin swelling and trismus. Chin swelling and trismus is Ludwig angina. But dental infection causing angle of mandible swelling and trismus is parapharyngeal abscess. I will read the question carefully. Okay, I hope it's clear. Chin swelling after dental infection with trismus, Ludwig angina. Angle of mandible, lateral swelling after dental infection with trismus is parapharyngeal abscess. Okay, now this is your oropharyngeal area. Okay, now this is called posterior pharyngeal wall. Right behind this wall is a space called the retropharyngeal space. Retropharyngeal space, and right behind that is prevertebral space. Right behind that is vertebra. So this is, guys, posterior pharyngeal wall. Right behind this you can see vertebra, and there is a retropharyngeal space, prevertebral space. In that space we have got some lymph node which are called retropharyngeal lymph nodes. Retropharyngeal lymph nodes. Now by chance abscess form, pus form, infection happen in the retropharyngeal lymph node. This will lead to an abscess, and that abscess is called acute retropharyngeal abscess. So retropharyngeal space has got retropharyngeal lymph node. If the pus form in this retropharyngeal lymph node, it will lead to a very serious clinical condition called acute retropharyngeal abscess, which is common in children, younger children, 2-year, 3-year children. Now please see, now what will happen? Here there will be a big abscess formation in this area. Now, this is a condition called acute retropharyngeal abscess, which is a pediatric airway emergency. Acute retropharyngeal abscess is a pediatric airway emergency. So retropharyngeal lymph node leading to infection, and that leads to acute retropharyngeal abscess, and that's a disease which is more common in children. It's a pediatric airway emergency. What will be the symptom of this patient? Patient will be having age profile of 2 or 3 years, very sick patient. It will be having a lot of respiratory difficulty. There will be inspiratory stridor, noisy breathing, difficulty in swallowing, patient not taking milk or feeds and all that, saliva is drooling out, and again the voice is hot potato or plummy voice. Now, if you do X-ray of this patient, you will see widening of prevertebral shadow. Now see on the screen, everybody, the vertebra are absolutely normal. But in front of vertebra, can you see this white shadow? This is depictive of collection of pus, in the retropharyngeal space. So this is actually the classical X-ray picture of retropharyngeal abscess, and this is widening of prevertebral shadow, but cervical spine is absolutely normal. This child will need immediate airway management first of all. It's a pediatric airway emergency. You can ask me, Rajiv, why it is not prevertebral abscess? So this is acute retropharyngeal abscess. What is prevertebral abscess then? Now, prevertebral abscess is a chronic tubercular abscess actually, which is orthopedic topic. That is due to TB of cervical spine. That is more common in adult patient. That's more common in adult patient. It's a chronic abscess. It is seen in adult patient. There's no airway issue in that because it takes months to develop, and more commonly in adults. And if you do the MRI of this patient or CT of this patient, you will see, of course, abscess in front of the vertebra. But more important than that, you will be seeing the characteristic feature of the port spine. You can see port spine feature. The cervical vertebral bodies are eroded. There is decreased intervertebral disc space and straightening of spine. All those characteristic orthopedic feature of port spine will be visible on that. So in the exam, I will not confuse acute retropharyngeal abscess with the prevertebral abscess, because prevertebral abscess is actually tubercular chronic abscess, more common in children, but acute retropharyngeal abscess is a pediatric problem, which is a pediatric acute airway emergency. Okay, let us talk about the laryngopharynx area. Now, all of us, we know that this is supraglottis. Above the vocal cord, supraglottis. If they ever show you two arrows like this, or one arrow on the side of the larynx like this is piriform sinus right, piriform sinus left, also called the piriform fossa. Don't confuse, it's a visual question of your paper. Piriform sinus, also called piriform fossa. If they ever show you two arrows on the side of the supraglottis, then those two arrows are representing piriform sinus right or piriform sinus left, and piriform sinus is same as piriform fossa. Please understand, internal branch of superior laryngeal nerve, which is also called internal laryngeal nerve, it gives sensory supply to supraglottis, and the same nerve gives sensory supply to piriform sinus also. Are you getting my point? Internal branch of superior laryngeal nerve, also called internal laryngeal nerve, it gives sensory supply to supraglottis, and number two, piriform sinus. Okay, so if they ever give you an MCQ that anesthetist has placed a cotton soaked in xylocaine in piriform sinus, which nerve is being blocked? Answer is internal laryngeal nerve block. Okay, fine. So I hope everybody clear. Internal branch of superior laryngeal nerve, also called internal laryngeal nerve, it gives sensory supply to two things. The answer is supraglottis and piriform sinus, and this is a very commonly asked clinical question of the paper. Okay, applied anatomy. Two structures lie in the bed of tonsil. Guys, please, if you remember, this is your oropharynx area. In the oropharynx area, this is your tonsil area. And in the tonsil bed, you have got two important structures. Number one is, of course, styloid process. And number two, there is a nerve over there, and that nerve is ninth nerve. Glossopharyngeal nerve is also lying over there. Okay, because two structures lie in the bed of tonsil, styloid process and glossopharyngeal nerve. But by chance, styloid process becomes very long. If long styloid process start pressing the ninth nerve, long styloid process start pressing the ninth nerve, it will lead to throat pain referred to ear. And this syndrome is called eagle syndrome or styalgia. You have styloid process, okay, everybody has it. Long styloid process, elongated styloid process, pressing the ninth nerve will lead to throat pain referred to ear, and this is technically called eagle syndrome or styalgia. How to remember the word eagle syndrome? Look at the eagle. We see eagle has got a long styloid process. The claw of the eagle holding the snake. The claw of the eagle represents the styloid process, and snake represents the ninth nerve. Okay, remember, visual pictorial memory is the best memory. Long styloid process represented by the claw of the eagle, snake represents the ninth nerve. That will help me recall in the paper eagle syndrome or styalgia. Treatment is styloidectomy. Now, there are two new surgeries in oropharynx which has come up. Laser palatoplasty, strengthening the palate with laser. This is the surgical management of snoring nowadays. Nowadays. Some people snore. Snoring has multiple causes. One cause may be palatal weakness. Palate is having flutter. So if you make the palate, strengthened by shooting a laser on that, laser palatoplasty, this is used for the snoring. Okay. Now there's another surgery which come up is uvulopalatopharyngoplasty, UPP surgery. This is done for obstructive sleep apnea. My dear friends, adenoid hypertrophy, tonsillar hypertrophy can also lead to obstructive sleep apnea. OSA, the extra amount of tissue in the palate is very low, uvula is very long, tonsil is very big. You remove all these tissues to make the breathing better during sleep particularly. So uvulopalatopharyngoplasty surgery is being done for which disease nowadays? Obstructive sleep apnea patient. So visual question, tonsillar lith. Tonsil has got crypts. There are invagination of epithelium in the tonsillar, tissue. Sometimes the keratinaceous debris can get stuck up. Can you see over here, beta? There is a collection of keratinaceous debris in one of the crypt, and that lead to tonsillar lith formation. So what is tonsillar lith? It's collection of keratinaceous debris in one of the tonsillar crypts, and that disease is called tonsillar lith. Tonsil. The main blood supply of tonsil is tonsillar branch of facial artery. There are 5 arteries which supply the tonsil. Let's revise quickly. Ascending pharyngeal artery, ascending palatine artery, descending palatine artery, and branches of lingual artery. But what is the most important blood supply of tonsil is tonsillar branch of facial artery. Now, anatomy question. What is the venous drainage of tonsil? The venous drainage of tonsil is paratonsillar vein. And paratonsillar vein is the main source of bleeding during tonsillectomy. When you do tonsillectomy, there's a lot of bleeding going on over there, and the main source of bleeding during tonsillectomy is paratonsillar vein, and paratonsillar vein is the main venous drainage of the tonsil. Now, what are the different type of hemorrhages in tonsillectomy? The hemorrhage in tonsillectomy is of 3 types: primary, reactionary, secondary. Primary is during surgery. Whatever bleeding happened during surgery on the table in the operation theater is primary hemorrhage. Now, patient comes out of the operation theater in the ward, postoperative ward. Then if the patient starts bleeding, that is called reactionary hemorrhage. Now, reactionary hemorrhage is within 24 hours of surgery, and patient is generally in the post-operative ward. Okay, ward. You will get a call in the evening of the surgery only that patient is bleeding, from the mouth. And this is due to slippage of ligature. Ligature on the stitch. Whatever stitch you applied to tie that vessel which was bleeding, it was loose, it came out, and it's a serious emergency. Patient is vomiting blood. Patient may aspirate the blood, may die immediately. So, what is the treatment of choice of reactionary hemorrhage? The answer is immediate re-exploration. How to remember this word, beta? RE reactionary, RE re-explore. Reactionary hemorrhage will need re-exploration. RE for RE. Okay. So reactionary hemorrhage is serious emergency. You need to explore the patient at the earliest, means take the patient to operation theater back, apply the stitch again. So RE reactionary, RE re-explore. Number 3, secondary hemorrhage. It's after 24 hours, mostly after 5th day of surgery. This is actually a delayed hemorrhage. Patient has gone home. Patient has been discharged. Reactionary hemorrhage was in the ward only. This is after discharge the patient. Patient has gone home. The story would be like that. Patient has been discharged, and after a few days again started bleeding. It actually is due to infection of the tonsillar fossa. The inside tonsillar fossa got infected, but it's a mild bleeding. Doctor, when patient spits, there's a red color in that, not too much of bleeding with that. So you need to readmit the patient to treat and start intravenous antibiotics. MCQ, secondary hemorrhage need intravenous antibiotics. Let us revise. Reactionary hemorrhage, re-exploration. Secondary hemorrhage, intravenous antibiotic. There is only mild bleeding due to infection. So secondary hemorrhage will be requiring intravenous antibiotic. Hemorrhage in tonsillectomy is a very important MCQ source for that. Let us do the differential diagnosis of whitish membrane on tonsil. There are n number of possibilities. What are the various causes of whitish membrane on tonsil? Number 1, the most common cause is acute membranous tonsillitis. Acute membranous tonsillitis, which is caused by Streptococcus pyogenes. The most common cause of whitish membrane on tonsil is acute membranous tonsillitis, which is caused by Strep pyogenes. Number 2, infectious mononucleosis, which is caused by Epstein-Barr virus, EBV, which is called the Epstein-Barr virus. Okay, now. Number 3, very important. Diphtheria is still very important, but don't forget diphtheria. Diphtheria membrane, 3 points to remember. Number 1, it's a pseudo membrane. Number 2, it bleeds on removal. Number 3, it extends beyond tonsil. Once again, diphtheria membrane, 3 points to remember. Number 1, it is a pseudo membrane. Number 2, it bleeds on removal. Number 3, it extends beyond tonsil to the palate. You can see over here also, it is extending beyond tonsil to the palate. Can you see? To the palate, to the posterior pharyngeal wall, and all those things. It's going beyond tonsil. Now, from some point with the patient, diphtheria patient will be baby, a sick child with fever and bull neck. Don't forget bull neck, bilateral cervical lymphadenopathy. Along with the membrane, the history will be a sick child with bilateral cervical lymphadenopathy called bull neck. Don't forget the word bull neck. And patient is very sick and patient is febrile also. Guys, don't forget, diphtheria can cause unilateral vocal cord palsy as a complication, and the treatment of unilateral cord palsy is conservative. Additional question of diphtheria. This is very popular clinical scenario. The treatment of choice of unilateral vocal cord paralysis is conservative because there should be a time 6 months for spontaneous recovery. So that's what keeping. Diphtheria can cause single-sided cord paralysis also. What is the best treatment for that? It's wait and watch policy. Okay, now what are the other causes? Number 1 was acute membranous tonsillitis. Number infectious mononucleosis, diphtheria. Number 4, of course, candidiasis. Number 5, Vincent angina, not Ludwig angina. Ludwig angina was in the chin area. Vincent is in the tonsillar area. Whitish membrane, grayish white membrane, dirty grayish membrane. Then malignancy and leukemia. Okay, don't forget about Vincent angina. Okay, Ludwig angina, chin. Vincent angina, tonsil. Vincent, T for tonsil. Vincent has T na. T will remind you something in the tonsil. Ludwig for chin. Now, Killian Dyson's, very famous question. It's a weakness in the pharyngeal design. Basically, Killian Dyson's is in the inferior constrictor muscle area between the fibers of thyropharyngeus and cricopharyngeus. So it's a triangular area in the inferior constrictor muscle between the fibers of thyropharyngeus and cricopharyngeus. Okay, so basically there is no muscle in this area. In the Killian Dyson's, there is no muscular support. It's a weak area. Therefore, Killian Dyson's is a site of formation of Zenker's diverticulum. Once again, Killian Dyson's is in which muscle? Inferior constrictor muscle between the fibers of thyropharyngeus and cricopharyngeus. Killian Dyson's does not have any muscular cord. It's a weak area of pharynx. Therefore, it is the site of formation of Zenker diverticulum or pharyngeal pouch. Okay. Now, famous question of ENT and radiology surgery, that coin like shadow in the X-ray. Now, the biggest dilemma they ask you in the paper is whether it is in the esophagus or in the trachea. Because in this region, 2 things are there: esophagus, trachea. Let us look at this piggy bank. Okay, and this piggy bank has 2 holes over there. And to make it easy for you, the front hole, this one is for the trachea. This for the trachea. Okay, and the back hole, this one is for the esophagus. Guys, why? This is the trachea. Okay, this is a trachea. Okay, trachea. Why? Because the longest diameter of the trachea is in the anterior posterior plane, and the longest diameter of the esophagus is from the side to side. Now, can you imagine if the coin is going through esophagus, then on the front X-ray, you'll be able to see the full shadow of the coin. Do you see over there? Do you see? Okay, fine. Now, can you see? If coin is in esophagus, what will happen? The coin would be fully visible on the front X-ray. This is the anterior-posterior view of the X-ray, and this is of course the lateral view. How to remember it? The rule of 3F, which we already discussed in the app also, in the class also, the rule of 3F. If full coin is visible on the front X-ray, means AP view, then the coin is in the food pipe, mean esophagus. Once again, if full coin is visible, like this one, I'm talking about this one. If full coin is visible on the front X-ray, means AP view, then the coin is in the food pipe, mean esophagus. Okay. Now let's put the coin in the trachea. trachea, like this trachea. The longest diameter of the trachea is in the anterior posterior plane. The coin will go like this. So now if you see the front X-ray, you'll be able to see the edge of the coin only. Please see, this is the coin in trachea. Can you see the coin in trachea? Okay, fine. So from the front X-ray, please see, this is the AP view or the front view. You can only see the edge of the coin like that. Okay, fine. Okay. Now, and on the side, you can see the full one. It's very easy with that. Remember, rule of 3F. Full coin, visible on front X-ray, answer is food pipe. Guys, please do remember, you will be needing an esophagoscopy to remove it. Okay, it's generally a rigid esophagoscopy, but it's not an urgent one, because if patient is stable, you can just give some time. There may be like some chance of spontaneous expulsion also, but there is no urgency. Okay, no urgency. Okay, fine. But if the child has swallowed by chance a disc battery, then you would be absolutely having urgent situation, because disc battery can release alkali and that can cause esophageal perforation. So in disc battery ingestion, you must do urgent esophagoscopy to remove it. In coin, you would need it, but it's not that urgent. Please see the essence of the question also, and it's a rigid esophagoscopy to remove these foreign bodies. These were the few important points of the pharynx for your revision for the examination. Well, my dear friends, let us start the revision of the main points of otology. The first thing would be a clinical scenario in which a female, which is a young 28-year-old with bilateral gradually progressive hearing loss. Guys, whenever a female is presenting to the OPD with bilateral gradually progressive hearing loss, you should always think of otosclerosis. Otosclerosis is a very famous clinical scenario asked in the paper. And few points about otosclerosis, please do remember, this lady can hear better in noisy surroundings, and that is called paracusis willisii. What is this called? Paracusis willisii. And the typical question given in the paper sometime is that the hearing loss in this female has worsened during pregnancy. Guys, any hearing loss worsened during pregnancy is a clue for otosclerosis. The otosclerotic focus is pink in color in early stages. Therefore, in the early stages, you will see Schwartz sign. What is Schwartz sign? Schwartz sign is flamingo pink appearance behind the tympanic membrane, and Schwartz sign indicates the early stage of disease. And in patients of otosclerosis, in which Schwartz sign is positive, we do not do surgery. In that case, we give sodium fluoride. So, otosclerosis patient with positive Schwartz sign, the treatment of choice is oral sodium fluoride therapy. Otherwise, the treatment of choice is, of course, surgery, in which we replace the fixed stapes with artificial stapes piston prosthesis. My dear friends, this is made of Teflon, or it can be made of titanium, and this is typically looking like a question mark. This middle ear implant looks like a question mark. Anything like a middle ear implant which is like a question mark, think of stapes piston prosthesis. Okay, and the name of surgery is stapedectomy or stapedectomy. The stapedectomy is the better word. And in this picture, you can see very clearly that what we have done is we have first opened the middle ear. The first step will be what? Tympanotomy. You open the middle ear, and then this is malleus, this is incus, and in place of stapes, you have put an artificial stapes piston prosthesis. So this is otosclerosis surgical management. Now, let us look at the next clinical scenario. Again, a female patient, but this time this lady has got pulsatile tinnitus or bleeding ear mass. There is some mass in the ear which bleeds to touch, that kind of history, or some pulsatile tinnitus in the ear is complained by the patient. Guys, this is a typical scenario of glomus jugulare, a highly vascular tumor of ear. ENT has two vascular tumor, one in young males called angiofibroma, the second in female is glomus jugulare. Any young boy with nasal mass and epistaxis is angiofibroma question. Any female with something pulsating or bleeding in the ear is glomus jugulare question. And this tumor typically gives which sign? Rising sun sign. It's a highly vascular tumor. It grows below the floor of the middle ear, and it's a benign locally invasive tumor. So it erodes the floor of middle ear and grows into hypodnepanum, and that gives rising sun sign. Okay. And on signalization, when you put air pressure on the tympanic membrane, the tumor shows blanching, and that is called brown sign. That is called which sign? Brown sign. Okay, fine. Now, there is a variant of glomus jugulare called glomus tympanicum. The glomus jugulare arises from glomus cells lying around the jugular bulb area. It's called glomus jugulare. Jugular bulb is below the floor of middle ear. if the similar type of tumor arises from glomus cells lying around promontory. And you know what is promontory? Promontory is the projection of the basal turn of the cochlea on the medial wall of middle ear. What is promontory? Projection of basal turn of the cochlea. Look at the star. Projection of basal turn of cochlea on the medial wall of middle ear. Around that promontory, there are some glomus cells. If the similar tumor arises from the glomus cells lying around promontory, the tumor will be named as glomus tympanicum. Okay. Otherwise, the more common variety is glomus jugulare. Next clinical scenario, a long-standing history of foul-smelling, blood-stained ear discharge. Foul-smelling, blood-stained ear discharge, the chronic history is there. Please think of atticoantral CSOM, more commonly called unsafe CSOM. The other name is atticoantral CSOM. Okay, so foul-smelling, blood-stained ear discharge for last couple of years. It is an indirect hint for the atticoantral CSOM or unsafe CSOM. The hallmark of unsafe CSOM is colostoma. They may twist the question like this also. They may give a picture to you. They give you a history of blood-stained, foul-smelling, ear discharge with the otoscopy finding given the picture. Guys, whenever you see a pearly white mass in the upper part of the tympanic membrane or the pars placida area, this is primary acquired colostoma. That the colostoma is the hallmark of the unsafe CSOM. Any colostoma which is actually being found in the pars placida area or the upper part of the middle ear area, it is primary acquired colostoma, which is due to retraction pocket, which we discussed amply in the app also, in the class also. Let us go to the next scenario. A long-standing history of foul-smelling, blood-stained ear discharge, same history with the vertigo. It means unsafe CSOM has shown some complication. You know, unsafe CSOM means colostoma. Colostoma has bone eroding properties, and vertigo in a patient with the unsafe CSOM history is an indirect hint for the labyrinthine fistula. What is labyrinth? Inner ear. What is fistula? Erosion. Why there is erosion? Because colostoma has got bone eroding properties. Next question is, labyrinthine fistula is a fistula of which canal of the inner ear? The answer is lateral semicircular canal. Colostoma has eroded the outer bony cover of the lateral semicircular canal, and this is the labyrinthine fistula, which is a complication of unsafe CSOM, and that leads to vertigo. In this case, fistula sign is positive. If you put ear in the ear by signalization, patient get vertigo and nystagmus. So positive fistula sign is a feature of labyrinthine fistula, which is a fistula of lateral semicircular canal. Now, next, another complication now. Again, long-standing history of foul-smelling, blood-stained ear discharge with headache. First of all, whenever you see a CSOM patient with headache, think of intracranial complication. Headache is a clue for intracranial complication. Vomiting, again, there's some increased CSF pressure, and convulsions. This is definitely, convulsion means some space occupying lesion has been over there most probably, and this is most probably a case of otogenic brain abscess. Unsafe CSM can have intracranial complication in the form of brain abscess, and which is called otogenic brain abscess. And the most common site of otogenic brain abscess will be which lobe? Can you see a CT scan? They will give you CT scan also along with the question. Okay, and this is temporal lobe abscess. It is otogenic brain abscess, and the most common site is of course the lobe above the ear. The answer is temporal lobe abscess. So convulsions, headache, vomiting in a backdrop of ear discharge is a case of otogenic brain abscess. And please, they'll ask you treatment also sometime. Treatment of this patient will be neurosurgery. First of all, you have to manage the brain abscess. Later on, you manage the unsafe CSM with the MRM. Now, there's another variety of colostoma called congenital colostoma. There's congenital colostoma is since birth. It's in the middle ear. So colostoma is pearly white in color. Look at screen. The pearly white mass behind intact tympanic membrane. The key word is intact. The pearly white mass behind intact TM. This is a typical question of congenital colostoma. And this criteria is called, this criteria is called which criteria? Levenson's criteria to diagnose congenital colostoma. Okay. So intact tympanic membrane, behind that you see a whitish pearly mass. It's a question of congenital colostoma. Now, Gradinego syndrome, petrositis. Okay. This is a very famous triad. How to remember it? Because At the petrous apex, if you remember, at the petrous apex, we have got two nerves. What are those two nerves? These two nerves are fifth and sixth nerves, and they get involved by the disease. So patient is having ear discharge, okay, and there is retroorbital pain due to fifth nerve involvement and diplopia due to sixth nerve involvement. How to remember it easily? G E R D. Gradenigo syndrome, other name of petrositis, has got three features. How to remember GERD? G for Gradenigo syndrome, E for ear discharge, R for retroorbital pain due to fifth nerve involvement, and D for diplopia due to sixth nerve involvement, because we know fifth and sixth nerve lie at the petrous apex area. Now, next one. Another clinical scenario. 6-year-old child, school-going child with mouth breathing and hearing loss. Guys, I've told you multiple number of times in the app also, class also, that mouth breathing child is a clue for adenoid hypertrophy. And adenoid hypertrophy patient with the hearing loss will be glue ear. Glue ear is the golden topic of ENT. Glue ear is the most common cause of hearing loss in children. That's why it's so important topic also. Okay. Can you see otoscopy? Can you see there are air bubbles behind the tympanic membrane? There are air bubbles trapped in the glue behind the tympanic membrane, and this is the question of glue ear, also called as serous otitis media, but the new name now is OME. The new name is OME. What is OME? Otitis media with effusion. OME. Okay, fine. Guys, whenever you see air bubbles behind the tympanic membrane, please mark glue ear. So the adenoid hypertrophy and glue ear are married to each other. A multiple choice question. Please keep in mind, mouth breathing child with hearing loss is the direct clue for adenoid hypertrophy with the hearing loss. Okay, fine. Okay. So guys, please keep in mind this story of mouth breathing child with the hearing loss. It is asked in the paper in the story format always. Okay. And for the glue ear, G for glue, G for grommet. Glue needs grommet. And what is the other name of grommet? Middle ear ventilation tube. And we do myringotomy first. We give an incision on the tympanic membrane and we put the grommet. In glue ear, we do myringotomy in anterior-inferior quadrant. This is your tympanic membrane. Where do you give cut? In the anterior-inferior quadrant. This surgery is called myringotomy. You suck the glue out. In the same hole, you put the grommet. Within few months, nature will push the grommet out. You don't need to remove the grommet. So glue ear, also called as serous otitis media. Now the new name is otitis media diffusion. Whenever you see the air bubbles behind the tympanic membrane in the glue, it's glue ear. It definitely, air bubbles are indicator of glue ear. Okay, fine. And grommet, G for glue, G for grommet. And grommet is placed after doing myringotomy in anterior-inferior quadrant of the tympanic membrane. Somebody is using matchstick or earbud and the traumatic perforation happen. Can you see a beautiful perforation over there? They can ask you, what is the treatment of choice of traumatic perforation of the tympanic membrane? The answer is wait and watch or conservative treatment. Please don't put any eardrops. No surgery should be done. It is going to heal spontaneously without any treatment in most of the cases. Just keep the ear dry. So treatment of choice of traumatic perforation of tympanic membrane is conservative treatment or wait and watch. No eardrops, no surgery, just keep the ear dry. Next question they can ask you, what is promontory? I told you already also, the promontory is a landmark on the medial wall of the middle ear. Promontory is the projection of the basal turn of the cochlea on the medial wall of middle ear. Let me point it out for you. This is the promontory area. Why? Promontory is the projection of basal turn of the cochlea on the medial wall of middle ear. Okay, can you see the star? Star represents the basal turn of cochlea and the arrow represent the promontory area. Okay, promontory. Don't confuse the word promontory with the pyramid. Now, what is pyramid? Pyramid is on the posterior wall of middle ear. Promontory on the medial wall of the middle ear. Pyramid is a projection on the posterior wall of middle ear. So this is your pyramid. From pyramid, which muscle comes out? Stapedius muscle comes out. And this attaches to which ossicle? This attaches to stapes. So pyramid is the projection on the posterior wall of middle ear. From pyramid, the tendon of stapedius muscle comes out. It attaches to stapes. Okay. Now, there are two bony spicules on the medial wall of middle ear. Okay. What are two bony spicules? Number one spicule is the ponticulus. Ponticulus, how to remember ponticulus? Ponticulus is from promontory to pyramid. P for ponticulus, it's from promontory to pyramid. Promontory to pyramid. P. Ponticulus is from promontory to pyramid. Number 2 is subiculum. Subiculum separates oval window from round window. Subiculum is between the oval window area and the round window area. How to remember? S for subiculum, S for separates. Okay. So there are two bony spicule on the medial wall of middle ear. Number 1, ponticulus is from promontory to pyramid. P. Number 2, subiculum, S for subiculum, S for separates. Subiculum separates oval window area from the round window area. Okay. Now, very scary thing for people is the medial wall of middle ear. They ask you landmarks here and there. Let us know them now. Yes, we all know the floor of the picture right now in front of you is the medial wall of middle ear. Majority landmark on the medial wall of middle ear. Okay. So let us see this picture. Let us label it. This is the P. P is P pyramid. This is pyramid is projection on the posterior wall of the middle ear. Remaining all landmark are on the medial wall of middle ear. From pyramid, once again, which muscle comes out? Stapedius muscle comes out. What is this ossicle? Stapes. Okay. What is this ossicle? Incus. Okay. And what is this joint? Incudostapedial joint. Incudostapedial joint. Okay. Now, what is this projection? This projection is promontory. I told you promontory is a projection of basal turn of cochlea on the medial wall of middle ear. Okay. What is this window? Oval window. Why? Because oval window is where the stapes footplate is attached. Okay. What is this window? This window is the round window. Okay. Then if you can see promontory, this one, you can see pyramid, then of course this will be what? This will be ponticulus. I hope remember ponticulus is from promontory to pyramid. Okay. Then what is this window? This is subiculum. Subiculum. Okay. Subiculum area. Subiculum is a bony spicule between the oval window area and the round window area. Between the ponticulus and subiculum, look at the star. This hidden area is called the sinus tympani area. Sinus tympani area. Okay. You can see ponticulus, you can see subiculum. Between the ponticulus and subiculum, star represents sinus tympani area. The sinus tympani is a hidden area in the middle ear. MCQ. Sinus tympani is the most common site of residual cholestoma after mastoid surgery. So once again, sinus tympani, superior boundary is ponticulus, lower boundary is subiculum. Sinus tympani is a hidden area in the middle ear. Sinus tympani is the most common site of residual cholestoma after mastoid surgery is done. Okay. Please do revise this picture once again later on. Okay. Now, next one. Inner ear development. Inner ear is a neuroectodermal structure. It developed from the neuroectoderm. Now, please see, basically, neuroectoderm makes two components actually. Now, this is of course the division. This much area developed from pars superior. Okay, pars superior. Pars superior develops two things. What is that? Semicircular canal and utricle. Okay. The lower area, the other area is from pars inferior. Pars inferior. It gives origin to cochlea and saccule. Cochlea and saccule. Let's revise. The inner ear development is from two things, pars superior and pars inferior. Pars superior gives origin to semicircular canals and utricle, and pars inferior gives origin to cochlea and saccule. It means that cochlea is the neighbor of saccule and canals are neighbor of utricle. Let us talk about cochlea. My dear friends, if you remember, cochlea has two 3/4 turns, and this turn of the cochlea is called basal turn of the cochlea. It's the basal turn of cochlea, and basal turn of cochlea is towards the oval window side. Okay, and of course, this is called the apex of cochlea. Please do remember, apex of cochlea is technically also called helicotrema. Helicotrema. Okay, helicotrema. Now, there's a most important rule is the basal turn of cochlea senses high frequency sounds, and apex of cochlea senses low frequency sounds. Very commonly asked question. The 8,000 hertz and more higher frequencies are heard at the basal turn. Apex hears low frequency sound. Please don't forget this. Basal turn is towards the oval window area side. Apex is also called helicotrema. Basal turn senses high frequency sounds. Apex senses low frequency sounds. Okay. What is modulus? Modulus is the central core around which the cochlear turns form. Modulus is the central core or central axis around which the cochlear turns form. Okay, the overview of the cochlea. Normal cochlea has got 2 3 by 4 turns. 2 3 by 4 turns, and if cochlea has got 1.5 turn, the deformity is called Mondini's dysplasia of cochlea. Mondini's dysplasia of cochlea. Okay, if cochlea, normal cochlea is 2 3 by 4 turns, but if cochlea got only 1.5 turn, it's called Mondini's dysplasia of cochlea. And my dear friends, please do remember that the cochlear implant surgery can be done in dysplastic cochlea also. Okay, so dysplasia of cochlea is not a contraindication of cochlear implant surgery. It can be done in the dysplastic cochleas also. Now, let's talk about the other part of inner ear now. So please see, as you now know, this is S. What is S? Saccule. What is U? Utricle. Saccule and utricle are meant for linear balance. And these are what? Beta semicircular canal. They are 3 canals. They are meant for what? Angular balance. Okay. Now, saccule and utricle have got macula. What is this red thing indicating? Macula is the sensory end organ of utricle and saccule. My dear friend, macula is covered by a gelatinous layer. This yellow is the gelatinous layer on top of the macula. In this gelatinous layer, we have got calcium carbonate crystals, which are called otoconia or otolith. Otoconia or otolith are calcium carbonate crystals in the gelatinous layer of macula. Now, due to unknown reasons, these otoconia otolith might get free from this gel and they enter the canals. Most commonly, they enter posterior semicircular canal. This will lead to disease called BPPV. If otoconia enter the canal, it will lead to disease called benign paroxysmal positional vertigo. Okay, most commonly, which canal is involved in BPPV? Posterior canal. The disease is more common in females. How does the patient MCQ will come? Clinical scenario, clinical vignette. 40-year-old female patient with brief episode of vertigo on changing head position. The moment doctor I change my head position, I feel dizzy for a few seconds only. Mind you, brief episode of vertigo. The doctor only when I change on my head position while lying down or I'm sitting, I lie down, I feel vertigo for a few seconds and then I'm all right. Is there any hearing loss in BPPV? No. Is there any tinnitus in BPPV? No. So only vertigo is there. There may be nausea, vomiting, which is a feature of vertigo, very commonly associated feature, but there is no tinnitus, no hearing loss in this patient. Okay, pure vertigo with nausea, vomiting on changing head position and vertigo for few seconds. This is definitely a case of BPPV, guys. Please do remember that benign paroxysmal positional vertigo, it is due to displaced otoconia, and otoconia enter the semicircular canals. Okay, and which canal most commonly affected? Posterior semicircular canal. It's more common in female. There is no hearing loss, no tinnitus in this patient. Now, how do we prove the BPPV? BPPV, the diagnostic test of BPPV is Dick-Solpike maneuver, and this can be a visual question of the paper. Now, Dick-Solpike maneuver, you will have 2 positions given in the exam. The first position is sitting position, and suddenly the doctor will bring the body of the patient down. And the moment you do this, patient will get vertigo and nystagmus, and that proves BPPV. This visual question with 2 pictures, 2 positions like this is Dick-Solpike maneuver, which is a diagnostic test of BPPV. Now, the treatment of BPPV is Appel's maneuver. Now, Appel's maneuver has got 5 positions. Okay, from sitting to lying down, to turn the head, to turn the body, and to sit up again. Okay, 5 positions are there. You're trying to send the otoconia back, and that is why Appel maneuver is also called the particle repositioning maneuver. Okay, Appel maneuver is the treatment of choice maneuver for BPPV. The other maneuver are Stemont maneuver and Brand-Daroff exercises as well for BPPV. I repeat, other maneuver for BPPV are Stemont maneuver and Brand-Daroff exercises for chronic BPPV. Okay, now let us do again for inner ear one more investigation. Vestibular evoked myogenic potential. V for vestibular. Vestibule means utricle and saccule area. vestibular evoked and myogenic potential. You have put the electrode on sternocleidomastoid muscle. So basically, you are giving a stimulation to saccule with loud sound, and you are recording the activity in sternocleidomastoid muscle. Vestibular evoked myogenic potential. So what is the principle of VAMP? You stimulate the saccule with loud sound, and you record the activity of sternocleidomastoid muscle. It is that's therefore called vestibular evoked myogenic potential, muscular thing. Okay, VAMP is a test of which area? Of course, saccule area. Beta. VAMP is a test of what? Saccule. And number two, VAMP, more importantly, VAMP tests which nerve? VAMP tests inferior vestibular division of 8 nerve. Very, very important question. VAMP tests inferior vestibular division of the 8 nerve. Therefore, VAMP is a useful test. Why this nerve is being tested by VAMP? Because this nerve is supplying the saccule actually. So let us see. VAMP tests which structure of the inner ear? Saccule. VAMP tests which particular nerve? Inferior vestibular division of the 8 nerve. And why so? Because this nerve is the supply of the saccule actually. Okay. Now, then another important topic is superior semicircular canal dehiscence syndrome. In this area, there is an opening created. This can be congenital or traumatic. My dear friend, nature gave you two windows, oval window and round window, and sound energy is going, and compression and rarefaction wave is there. But unfortunately, another window got created. Now, due to this dehiscence, the sound energy will not be conducted properly to the inner ear. There will be leakage of sound energy from this dehiscence. So therefore, this patient will be having conductive hearing loss. Not SNHL, conductive hearing loss. Now, this is called third window phenomenon. Very famous question, third window phenomenon. Don't forget this word. Third window phenomenon is a feature of superior semicircular canal dehiscence syndrome. What do you mean by third window phenomenon? Patient suffers conductive hearing loss due to leakage of sound energy from this dehiscence. This is called third window phenomenon. This patient also have the problem of vertigo on hearing loud sound. This is called Tullio's phenomenon. This is called Tullio's phenomenon. So third window phenomenon and Tullio's phenomenon. But Tullio phenomenon is vertigo on hearing loud sound. Does this patient have got SNHL or CHL? The patient does not have SNHL. Patient has got conductive hearing loss. Okay. And the patient will also give sometimes history of, vertigo on blowing of nose also. Patient says, doctor, when I blow the nose very forcefully, I get vertigo. Vertigo on blowing the nose also is a clue for the superior canal dehiscence syndrome. How to diagnose this is HRCT, high resolution CT of the temporal bone. So this is an important topic. Third window phenomenon, Tullio's phenomenon, conductive hearing loss. Now, let us identify the ossicles better. There's malleus incus stapes. My dear friend, no need to get confused between malleus incus better, because people say no. Stapes is definitely like a horseshoe over a plate like that, cup and a plate. So how to differentiate malleus from incus? That's very simple. Malleus is like a head, hammer, and every hammer has a head. This is the head of the malleus. Head. Can you see head? This looks like a head also. Incus has a body. Body has to be little flat like that. Okay, like that. Okay. Can you see head on one side, body? Somebody is lying down on the beach, head on one side, globular head. If it has got a globular head, it has to be malleus. If the flattened kind of thing on the top, it has to be body. Incus has a body, malleus has a head actually. Malleus is like a hammer. Every hammer has a head. So with the head, globular head like thing will be malleus. With the flat body at the top will be incus. Okay, fine. Yes, malleus incus develop from first arch. Head of stapes develop from second arch. Footplate of stapes develop from neuroectoderm. Okay, fine. Once again, malleus incus develop from first arch. Stapes head develop from second arch. Footplate of stapes develop from neuroectoderm. Syringing of the ear to remove the wax. We can do syringing. Some point about syringing. Number one, direction of syringing is posterior superior. Number two, never use cold water because it can lead to vertigo due to inner ear stimulation. Number three, during ear syringing or during cleaning the ear with the probe, patient might develop cough. What is the cause behind cough? The answer is stimulation of auricular branch of vagus nerve, which is also called Arnold's nerve. And the same nerve stimulation can lead to syncopal episode also, or vasovagal episode, patient turning unconscious during syringing. They may make a very clinical applied anatomy question. You were doing syringing or cleaning the ear of the patient, and patient is suddenly developed, either cough or patient developed, syncopal or vasovagal or turned unconscious. It is due to stimulation of which nerve? Auricular branch of vagus nerve. And that is also called Arnold's nerve. And vagus is parasympathetic nerve. And parasympathetic stimulation is going to cause bradycardia, hypotension. That's why sometimes people develop syncopal episode during syringing or cleaning the ear with the probe. Very, very important applied anatomy question. If somebody gets a live insect in the ear, if cockroach goes in the ear, what will you do? Don't try to catch it live. There is no 5 lakh rupees prize on catching it live. First, put oil in the EAC to kill it and then remove it. Put oil in the EAC to kill it and remove it. Okay. Somebody asked me which oil. I said any oil except kerosene oil. Okay, not kerosene oil, of course. You can use mustard oil. Take some more mustard oil, put the oil, kill it, and then remove it. Because if you try to catch it live, it might damage the structure of the ear. Okay, there are arthropods with the 3 pair of limbs. Clinical scenario, very commonly asked: 60-year-old diabetic patient presenting with earache, blood-stained ear discharge, and facial palsy also may be there. Guys, old patient with ear problem is malignant otitis externa. Guys, very, very important thing is, malignant otitis externa is common in old diabetic patient, and facial nerve is very commonly involved because this is the infection of underlying bone of the EAC. Okay, and the causative organism is Pseudomonas. Facial nerve is very commonly involved now. Okay, because facial nerve passes through the bone of the ear. It's a bone infection only. It's infection of underlying bone of the external auditory canal. It is seen in elderly diabetic patient, and the causative organism is Pseudomonas, and facial nerve is the most commonly involved now. It's a skull-based osteomyelitis. It can spread on the skull base and can damage other cranial nerves also. What is the first scan you order for this patient? The answer is technetium bone scan. The first scan to be done for this patient to see the bone infection, technetium bone scan. The follow-up scan is gallium bone scan. Okay, fine. The first bone scan will be technetium bone scan, and the follow-up scan will be gallium bone scan in this patient. What is the drug of choice for this patient? The drug of choice for this patient will be 3rd generation cephalosporins. Preferably along with aminoglycosides. Okay, please see the question carefully. Generally, they give 3rd generation cephalosporin as a choice, but in the reality, Pseudomonas, we give combination antibiotic. So 3rd generation cephalosporin with aminoglycoside combination is a better answer than pure 3rd generation cephalosporin only. Okay, fine. Now, anatomy question, visual question. If they ever show you like this, a structure being pointed on the posterior wall of the posterior aspect of the temporal bone, it is internal auditory canal. Internal auditory canal is the entry point of 7th and 8th nerve into the ear. And I hope remember Bill's bar. Bill's bar is a vertical bony septum in the upper part of the internal auditory canal. Okay, so if they ever show you with a pointer a hole in the posterior aspect of the temporal bone, it's internal auditory canal. And don't forget, Bill's bar is actually the bony septum in the upper part of the internal auditory canal. Now, pinna hematoma, trauma may be there, some injury happened, hematoma. Guys, please drain it or aspirate it immediately. Pinna hematoma should be aspirated or drained immediately because it can lead to necrosis of underlying cartilage. If you don't drain it, if you don't aspirate it, it can lead to necrosis of underlying cartilage, and that can lead to pinna deformity called boxer ear or cauliflower ear, which is a post-trauma pinna deformity. So boxer ear or cauliflower ear is a sequelae to pinna hematoma. So pinna hematoma should be drained immediately. Otherwise, it can lead to cartilage necrosis. That will lead to the problem with the shape of the pinna, and this is also commonly called cauliflower ear or boxer ear. So it is post-traumatic pinna deformity. The other name is boxer ear or cauliflower ear. Now, what is bat ear? There's normal pinna. If you see your pinna, you have 2 curvature. The outer curvature is, helix, Inner curvature is anti-helix. So you have a 2C, but the outer C is helix, inner C is anti-helix. But if anti-helix is not there, look at this patient, beta. There's no anti-helix in this patient. The absence of anti-helix is called bat ear. Your pinna has 2C, outer C also, inner C also. If inner curvature, anti-helix is absent, it's called bat ear, and the surgery will be called otoplasty, and the ideal age of this surgery will be 6 years. Why? Let the pinna grow fully. By 6 years, pinna almost attains adult size. So that's the best. 6 years or later should be the time of the otoplasty surgery in these cases. Now, Darwin tubercle is not a disease, it's anatomical variation. Can you see this one? This is a conical elevation on the helix. Darwin tubercle is not a disease, it's an anatomical variation. Some people have got a conical elevation on the helix, and that's called Darwin's tubercle. Okay. Now, again, one anatomical landmark. Now, this surgical specimen, the temporal bone specimen, has got an orange arrow pointing at a structure. First of all, what is this big hollow cavity? This is a mastodectomy cavity. So this is a temporal bone specimen. So I've labeled like that. What you are seeing as the big cavity is the mastoid cavity. And can you see axonoid canal over there? Yes. Okay, fine. This is the mastoid cavity. This whole hole is the mastoid cavity. Now, if you see a bulge, like this is the bulge they are pointing, if you see a bulge or projection or elevation in the floor of the mastoid cavity, this is lateral semicircular canal bulge. So any projection or any, you can say, bulge in the floor of the mastodectomy cavity is actually lateral semicircular canal bulge, and it is a landmark for, this is why it is important for surgeons. It's a landmark for second genu of the facial nerve. You can ask me, Rajiv, what is the surgical landmark for first genu of the facial nerve? The first genu, which is the house of geniculate ganglion, the first genu, the surgical landmark is processus cochleariformis. Once again, lateral semicircular canal bulge is a surgical landmark for second genu. The processus cochleariformis is the surgical landmark for the first genu of the facial nerve. Now, facial nerve gives one branch in the ear. It gives 3 branches total. Very important branch is chorda tympani, and this can be a visual question for you in the exam. If they ever show you something like this, a nerve passing between the malleus and incus, it has to be chorda tympani. So if they ever show you a naked nerve passing between the malleus and incus, which nerve passes like this in the middle ear cavity as a naked nerve between the malleus and incus, it is chorda tympani nerve, which is a branch of vertical segment of the facial nerve. Okay, fine. Now, Bell's palsy, very important for neurology medicine also. Bell's palsy is idiopathic, sudden onset, lower motor neuron facial palsy. Okay, is it unilateral, bilateral? It's mostly unilateral. Okay, now are the forehead muscles also involved? Yes, they are involved. Forehead muscles are also paralyzed. Okay, fine. Angle of mouth is deviated to normal side. This is normal side. Okay, this is disease side. Okay, the forehead muscle are also paralyzed. Angle of mouth is deviated to normal side. Okay, eye is continuously open, and in the ear, patient will be having what? Hyperacusis. Hyperacusis is due to loss of stapedial reflex, because stapedius muscle is supplied by the nerve to stapedius, which is branch of facial nerve only. Okay, so let's revise once again. There is the forehead muscle are paralyzed or not? Yes, they are paralyzed. Angle of mouth is deviated to normal side. In the ear, patient complain of hyperacusis. Hyperacusis due to loss of stapedial reflex. Okay, what is the cause of Bell's palsy? It is edema in the labyrinthine segment of the facial nerve, which is the narrowest segment of the facial nerve, and that edema leads to compression. People hypothesize that this edema is due to herpes simplex virus 1 infection, but it is not proven. Drug of choice for Bell's palsy is oral steroid therapy for 3 weeks. Okay, acyclovir is only given if patient come within 3 days. 85% patients show wonderful recovery. If patients do not show any recovery after 3 weeks of steroid therapy, then we do next management as electrophysiological nerve testing to assess the degeneration of the facial nerve fibers. Okay, once again, Is there any role of acyclovir? Only in the first 3 days. What is the drug of choice? Oral steroid. For how many weeks? 3 weeks. Which segment of the facial nerve is involved? Labyrinthine segment. Okay. How many patients recover? 85% patient recover. Are forehead muscle paralyzed? Yes. Angle of mouth is pulled towards normal side. In the ear, which cues? Hyperacusis. If patients do not show recovery after 3 weeks of steroid therapy, the next management is electrophysiological nerve testing. Let us revise the 4 Qs which are asked in the exam. Presbycusis is age-related SNHL, which is bilateral. Like presbyopia, presbycusis is age-related sensory neural hearing loss. Diplicusis, doctor, I hear same sound in 2 different frequencies, is a feature of Meniere's disease. Hyperacusis, as we discussed just now, Bell's palsy. Paracusis villi is a feature of otosclerosis. Once again, let's revise. Presbycusis is age-related SNHL. Diplicusis is a feature of Meniere's. Hyperacusis is a feature of Bell's palsy, and paracusis villi is a feature of otosclerosis. Now, very important question for anatomy, for ENT medicine both, Ramsay-Hunt syndrome, which is due to the reactivation of varicella-zoster virus. Now, what is the site of lesion in this? The answer is geniculate ganglion. So, geniculate ganglion. Where does this virus reside? In the geniculate ganglion at the first genu of the facial. Now, what are the typical features? There is painful vesicles in the external ear, and number 2, lower motor neuron facial paralysis. Okay, same. You know, the herpes zoster involve the nerves. So there are painful vesicles in the external ear, and there is lower motor neuron facial paralysis, and the patient would need acyclovir plus steroid therapy. But facial recovery is seen in 50% cases only. Okay, Ramsay syndrome, the site of lesion is geniculate ganglion of the facial nerve. Now, Melkerson-Rosenthal syndrome, very possible question of visual question in dermatology also. It has got 3 features. Number 1, recurrent facial palsy. Number 2, fissured tongue. And number 3, swelling of lips. Let's revise. What is the name of the syndrome? Melkerson-Rosenthal syndrome. The 3 features are, number 1, recurrent facial palsy. Number 2 is fissured tongue. Number 3, swelling of lips. Now, let us do some devices now. Cochlear implant, a very important topic. Indication of cochlear implant is bilateral profound SNH. Bilateral. Patient is totally deaf both sides. Bilateral. Profound means more than 90 decibel hearing loss with the normal 8 now. This is important. MCQ. This is the prerequisite of cochlear implant surgery, because cochlear implant is going to do the electrical stimulation of the cochlear nerve endings. So before doing this implant, you must prove that 8th nerve is normal. So do an MRI to see 8th nerve functional and anatomical integrity over there. So what is the indication of cochlear implant? Bilateral profound SNHL with normal 8th nerve. The cochlear implant has got 2 components, one outside the body, one inside the body. Outside body external component, and external component has got 4 parts. 4 parts, which you wear over here as like a hearing aid. Number 1 part is microphone. Microphone. Number 2 is transmitter. This can be a question. Transmitter is on the hair over here. Transmitter is a circular part. It transmits current to the internal component. Number 3 is speech processor, and number 4 is battery. Let's revise once again. The external component of cochlear implant has got 4 parts. Number 1, microphone. Number 2, transmitter. Number 3, speech processor. Number 4, battery. Transmitter is the circular part which transmits current to the internal component. This is about the external component. Let us do the internal component. The internal component is called electrode. Now, where do we put the electrode? Because cochlear got 3 parts: scala vestibuli, scala media, scala tympani. And cochlear has got 2 windows: oval window and round window. The answer to this question is the cochlear implant electrode is placed into scala tympani of the cochlea. Through which window? Through round window. Through round window. Okay. So the cochlear got 3 parts. If you remember, scala vestibuli, scala media, and scala tympani. The electrode is placed in scala tympani through which window? Through round window. 2 questions over there. This is cochlear implant. Cochlear implant can be done in dysplastic cochleas also. Okay. Fine. Now, there's another implant where cochlear implant doesn't work. We have to go for auditory brainstem implant. You have to put the implant right in the brainstem area. And what is the primary indication of ABI? What is ABI? Auditory brainstem implant. Okay. The main indication of ABI is neurofibroma type 2. Neurofibroma type 2 has got bilateral vestibular schwannoma or bilateral acoustic neuroma. Acoustic neuroma is the old name of vestibular schwannoma, means eighth nerve tumor both sides. I told you cochlear implant, the main prerequisite of surgery is normal eighth nerve. But in this case, both eighth nerve are abnormal because both of them have developed the tumor. So this patient would not be the good candidate for cochlear implant surgery. This patient would be a good candidate for auditory brainstem implant surgery. What are the other indications of ABI nowadays? The other indications are congenital aplasia of the eighth nerve. There may be cases in which eighth nerve is not formed since birth. Okay, I told you the main prerequisite of cochlear implant surgery is normal eighth nerve. So in neurofibroma type 2, eighth nerve has gone diseased. In congenital aplasia of the eighth nerve is absent. And third indication is aplasia of the cochlea, called Michel's aplasia of the cochlea. So let's revise once again. What are three indications of auditory brainstem implant surgery? Number one, neurofibroma type 2. Number two, congenital aplasia of the eighth nerve. Number three, the Michel's aplasia of the cochlea. Next question is, where do we put the ABI electrode? Again, it's an electrical device. You have to put the electrode in the brainstem area. The answer to this question, very famous question, is lateral recess of fourth ventricle. Repeat with me. What is the location of cochlear implant electrode? Cochlear implant, scala tympani of the cochlea. What is the location of ABI electrode? The answer is lateral recess of fourth ventricle. Okay. Now, next device, the third device. This very popular device nowadays. This is BAHA. BAHA. BAHA full form, bone anchored hearing aid. Bone anchored hearing aid means you anchor the hearing aid onto the bone. Okay. It has got the three parts. Number one, the titanium screw. First of all, it's a specialized surgery in which you put a titanium screw onto the skull bone, and then number two, sound processor. Then you attach the external sound processor to the screw through an attachment called abutment. Abutment. Let's revise. The three parts of BAHA are the titanium screw, which is fixed on the skull bone, and then sound processor is attached to the same screw through an attachment called abutment. BAHA is a specialized surgery. BAHA transmits sound directly to cochlea through bone conduction. Okay, BAHA, bone anchored hearing aid. What are the primary most important indication of BAHA nowadays? Number one is EAC atresia. When the canal is blocked from outside, you cannot use the conventional hearing aid. Number two, chronic discharging ear. If ear is full of pus, you can't put the hearing aid because hearing aid will be spoiled to moisture within 1 day. Anoxia, pinna is absent with hearing loss. If pinna is not there, you cannot support the hearing aid. So you will have to anchor the hearing aid on the skull with the screw. And number four is unilateral severe SNHL. Unilateral severe SNHL. So let's revise once again. What are the indication of BAHA? EAC atresia, chronic discharging ear, anoxia with hearing loss. What is anoxia? Absence of pinna, and unilateral severe SNHL. Guys, devices, cochlear implant, brainstem implant, BAHA are very important topics for the examination. Okay. Now, another new device, or can say thing we use in the ENT is microwick. Microwicks are being used in ENT. What are microwicks for? Yes, please see. This is your external canal in front of you. This is your EAC. Okay, and this is the wick I'm talking about. This is your middle ear, and this is your inner ear. Now, when you want to inject some drug in the middle ear, you don't need to put injection again and again. So microwicks are used in ENT for transtympanic injections. Transtympanic injection. You want to put steroids, or you want to put anything in the inner ear. So don't put injection again and again. Just do one thing. Ask the patient to put the drops from here at home only. This will absorb and this will send the medicine to the inner ear. Okay, fine. So microwicks in ENT are used for transtympanic injection of the drugs. Okay, now let's talk about something about audiology. Now, tympanometry, also called impedance audiometry, it has got 5 types of curves. Type A is normal curve. Type A, normal curve, very beautiful curve. Type B is flat curve. And the type B curve is seen in the blue ear. And type C curve is seen in the negative side of the zero. And type C curve is seen in the retracted tympanic membrane or eustachian tube dysfunction cases. Let's revise once again. The type A, can you see? Type A is beautiful curve. It's seen in normal people. It's standing on the zero, equal on negative and positive side both. Now, important thing is type B curve. Very famous question, glue ear. The glue ear is very important topic I told you. Type B curve or flat curve. Don't forget this one. Look at the visual also. Type B curve or flat curve is seen in glue ear, and there's no movement of tympanic membrane on change of pressure in the ESC beta. And type C curve. Can you see beta? This is only on the negative side. There is no movement on the zero side, actually the positive side. The negative side movement, if you see, it's type C curve. It's seen in Eustachian tube dysfunction or in the retracted tympanic membrane cases. Let's revise. Type A is normal. Type B, flat curve is glue ear. The type C curve, negative side curve, is feature of Eustachian tube dysfunction or retracted tympanic membrane. And the last two more are AS curve is seen in otosclerosis, and AD curve is seen in ossicular dislocation. AS curve, as for sclerosis, AS curve is seen in otosclerosis. It's a low compliance curve actually, otosclerosis, and AD curve is seen in ossicular dislocation. Okay, fine. Now, OAE, otoacoustic emission. OAE, otoacoustic emission, is a very commonly used thing in ENT nowadays. Basically, what you do is you give sound to the ear and you record echoes from the outer hair cells of the cochlea. Can you see over here? Can you see this baby also? You're giving sound to the cochlea and you're recording the echoes from outer hair cells of the cochlea, and those echoes are called otoacoustic emission. If echoes are coming, it is actually the normal cochlea. Okay, so one question is, echoes are produced by which part of cochlea? Outer hair cells of cochlea. Easy to remember. OHC, outer hair cell of cochlea, and they produce OAE, otoacoustic emission. Very simple test for use for screening of the hearing in babies. Otoacoustic emission are produced by the outer hair cells of cochlea. These are echoes of the cochlea. When you give sound to cochlea, the outer hair cells of the cochlea produce some echoes and they are recorded by the machine, and they're called otoacoustic emission, and they are produced by outer hair cells of the cochlea. There is another test which we do very commonly in ENT, and when you put the electrode on the forehead and all that, and very commonly done in the babies also. This is BERA, also called ABR. BERA or ABR. What is full form of BERA? Brainstem evoked response audiometry, also called auditory brainstem responses. Why the word brainstem comes very commonly in here? Because most of the auditory pathway lies in the brainstem area. That's why they say the word brainstem. So once again, what is full form of BERA? Brainstem evoked response audiometry. It's also called ABR, auditory brainstem responses. Very simple test, beta. We give sound to the ear and we record the electrical activity from brain. That's all. Okay. Basically, it's EEG, evoked EEG only. Now, BERA has 7 waves. You can see 7 waves over there. The most important wave in BERA is wave 5. Okay. You give sound to the ear and you record the electrical activity from brain, and it's evoked EEG. BERA records multiple waves. There are 7 waves, and the most important wave of BERA is wave 5, and wave 5 is produced by lateral lemniscus. Lateral lemniscus is the part of the auditory pathway. Okay, so wave 5 is produced by lateral lemniscus. Lateral lemniscus. Okay, fine. Guys, auditory pathway is important question. The mnemonic auditory pathway is E. coli ma. Auditory pathway lies in the brainstem area majority. E for 8th nerve, C for cochlear nucleus, O for olivary complex superior, L for lateral lemniscus, I for inferior colliculus, M for medial geniculate body, and A for auditory cortex. Once again, E for the 8th nerve, C for cochlear nucleus, O for olivary complex superior, L for lateral lemniscus, I for inferior colliculus, M for medial geniculate body, and A for the auditory cortex, which lies in the superior temporal gyrus. Now, they can ask you one advanced question. Where does the decussation happen? The crossover of information happen from right to left side and vice versa at the level of the olivary complex area. Okay, at the level of olivary complex, the crossover information happen from the one sphere to the other sphere. Okay, fine. Because the auditory pathway majorly lies in the brainstem area, that's why BERA, the full form is brainstem evoked response audiometry, and the source of wave 5 is lateral lemniscus. Now, few question about screening protocols. The ideal investigation for neonatal hearing screening If the MCQ says neonatal hearing screening is otoacoustic emission. But if the MCQ says the high risk hearing screening, like a meningitis baby or a low birth weight baby or a syndromic baby, then you go for BERA. Once again, a general question about the neonatal hearing screening, the ideal investigation would be a simple test like otoacoustic emission. But in a high risk baby, like a meningitis baby, NICU baby, what is the best investigation for screening is BERA, brainstem evoked response audiometry. Now, PTA, pivotal audiometry, okay. Now, it's a subjective investigation. Patient has to respond to you, are you hearing it or not? This is air conduction testing, and this is, of course, the bone conduction testing. Air conduction and bone conduction testing. Okay. Now, in audiometry, we have to see the hearing threshold of patient. Like vision 6/6 is normal. If you can hear starting from 25 decibel, your hearing is normal. Your hearing should be above 25 decibel zone. It means your hearing is absolutely okay. Okay, fine. Like 6/6 is normal. We have to define up to what level. If you start hearing, you are called as normal hearing person. If your hearing start from 25 decibel zone, you are absolutely having normal hearing. Now, that's how we look at this thing. The audiometry, there is one side is frequency. Can you see 250 to 8000 hertz? This is frequency. And this is decibel beta. 0, 10, 20, 25. Now, this is the normal zone. Can you see? Your hearing result should come in the normal zone. If you come in this zone, you have got mild hearing loss. If your hearing line come in this zone, you have got moderate hearing loss. If you hearing result come in this zone, severe hearing loss. And here you are having profound hearing loss, means almost deaf patient. So in this test, score more towards 0. In this test, score more towards 0 you are, better hearing you have. Don't score 100 out of 100 in this test, beta. Don't feel, oh, I scored 100 out of 100. Don't feel very happy about it. 100 out of 100 means you are deaf. Sorry, you are deaf, beta. So be towards 0, better it is actually. Okay. So hearing line should be above 25 area. Now, we use some symbols for this beta. For ear conduction, we use circle and cross majorly beta. Circle is for right ear and cross is for the left ear. Okay. And for bone conduction, B for bone, B for brackets. We use these kind of symbols. Bracket-like symbols are bone conduction. Circle is for right AC, cross for left AC. This you must remember for the exam. This bracket-like symbol are bone conduction symbols. Circle is right AC and cross is left AC. Sometimes they give you colorful audiogram. For that, red lines are for the right ear, blue lines are for the left ear. It's a rule. Okay. By chance they give you. Mostly they give you black and white. But if you give colored audiogram, red lines are for the right ear, blue lines for the left ear. Now, please understand, whenever you see AB gap, means a gap between the air conduction and bone conduction line, it's conductive hearing loss. And if both AC, BC are poor, then patient is suffering from sensory neural hearing loss. Very important thing, AB gap. If there is an AB gap, it's conductive hearing loss. If both AC, BC are poor means below 25, you are suffering from sensory neural hearing loss. Now, let me show you normal audiogram. Don't get scared, it's not that difficult. This is frequency. Can you see 250 to 8000 hertz frequency? And this is, of course, decibel. Decibel. Now, this is left side audiogram. Why? It's blue in color. Anyway, cross is for left ear AC. Cross left ear AC. And this is, of course, the bone conduction symbol. This is air conduction symbol. And up to 25. I told you, if your hearing results are coming in this zone, you have got a normal hearing actually. So this is normal hearing audiogram. Okay. Let me tell you a secret of ENT. Bone conduction line is always above. Upper line is always a bone conduction. Okay. Just remember this crude rule actually there. Upper line is always bone conduction. Okay. Now, conductive hearing loss. Please see this again, left ear. Why? Cross. Cross is for the left AC. Blue color, again left ear. This is bone conduction. Can you see bracket like symbol? Okay. Any upper line is always BC. Bracket like symbol is BC. It's normal. This is, of course, AC line. AC line. And this is poor. Up to 25 is normal. So it means that BC is normal in this patient. AC is poor. And this gap is called AB gap. AB gap is feature of conductive hearing loss. So this patient is suffering from left conductive hearing loss. Once again, I make you revise. This is a left audiogram. Why? Blue color. Okay, it's black and white. Then what? Cross represent the left AC. Okay, fine. Now, BC is normal. Why? Any line above 25 is normal. AC is poor. Why? Any line below 25 is poor. So AC is poor. What is this gap called? AB gap. And AB gap is the hallmark of conductive hearing loss. Okay. Now, in sensory neural hearing loss, when cochlea is not working properly, you go through air conduction or you go through bone conduction, both will be poor now. So let us see the SNHL beta. Please see SNHL of the left side. Okay, can you see the blue color? Okay, and please see this is 0, 10, 20, 25. Both have come below 25. Normal zone was this zone. Both AC and BC have come down, and this is left SNHL beta. That's all. It's not that rocket science. I don't know why to get confused. Beta. If both lines are below the 25, it's SNHL case. Beta. Why it is left here? Again, blue color, left here. Okay, color is not given. Cross is given. Huh? This cross means what? Cross is what? Left here AC. Beta. Okay, fine. Now, if it is a mixed hearing loss, then what? Mixed hearing loss will have mixed feature of both. Means both AC, BC poor, AC, BC poor with AB gap. With AB gap. Both AC, BC poor with AB gap. Okay, fine. Now, let's see these one by one. Now, please see the first one. This is normal. Normal. Because both lines are above the 25. Now, number 2. This is BC, AC. I told you upper line always BC beta. Okay. And this is what beta? AB gap. So, this will be conductive hearing loss. Okay. Now, this one number 3. Both AC, BC are below 25. This will be SNHL. SNHL. Number 4. Please see. This is BC, AC. Both are poor with AB gap. This is mixed hearing loss. This is mixed hearing loss. Can you see? In the fourth one, please see. Both BC and AC are poor, but there is an AB gap also. There is an AB gap also. So when both AC, BC are poor with AB gap, it's a case of mixed hearing loss. Let's try once again. First one is normal. Okay, fine. Second is AB gap, conductive hearing loss. Third is both AC, BC poor, SNHL. Fourth is AC, BC poor with AB gap. It's the mixed hearing loss pattern. Now, 2 dips and 2 special audiogram in the end. 2 dips are, one dip is seen in otosclerosis, which is dip at 2000 Hz in bone conduction curve. In otosclerosis, you see a typical dip at 2000 Hz in bone conduction curve, and that dip is called Carhart's notch. Can you see Carhart's notch, beta? This is Carhart's notch. This is the 2000 Hz. This is which line, beta? Bone conduction line. And this dip is called Carhart's notch, and Carhart's notch is a typical of otosclerosis. Otosclerosis, the name of dip is what? Carhart's notch. It is seen at 2000 Hz in AC or BC? In BC, beta. What is this line, beta? AC. What is this gap called? AB gap. AB gap is feature of what? Conductive hearing loss. And we know otosclerosis patient has got conductive hearing loss. Can you see beautiful description over there? It's not that difficult. Beta. Once again, Carhart's notch is a dip at 2000 Hz in bone conduction curve. And there is AB gap also in otosclerosis. And AB gap means conductive hearing loss, because we remember otosclerosis is a cause of conductive hearing loss. The second dip is seen in noise-induced hearing loss, and this is dip at 4000 Hz in AC and BC. Carhart's notch is dip at 2000 Hz in BC. Noise-induced hearing loss dip is called the acoustic dip, and it is seen in 4000 Hz in AC and BC. Okay, fine. So this is noise-induced hearing loss, and this dip is called acoustic dip, and this is seen at 4000 Hz, and this is a dip in AC, BC both. Let's revise once again. Carhart's notch dip at 2000 Hz in BC is a feature of otosclerosis. Acoustic dip at 4000 Hz in AC, BC is a feature of noise-induced hearing loss. This is also called Boiler's notch because it's common in the industrial areas actually. Okay. Now, in then 2 type of audiogram beta, presbyacusis and mean ears beta. Now please see, presbyacusis is age-related SNHL. It has to be bilateral. Both cochlea are damaged. Okay. And it causes high frequency SNHL. If you remember, I told you the basal turn of cochlea senses high frequency sounds. It means that age damages high basal turn first. Age damages basal turn of cochlea first. So presbyacusis will be having high frequency SNHL in early stages. So there will be a sloping curve. How to remember? Age slopes you down toward your grave, beta. Age is sloping you down gradually. Okay. The second one is mean years, beta. Guys, mean years, remember, mean years is a unilateral disease. Presbycusis is bilateral. And mean years causes low frequency SNHL. If you remember, apex of cochlea senses the low frequency sound beta. So it means that meanius damages apex of cochlea first. Age damage basal turn of cochlea first. Meanius damages apex cochlea first. So meanius patient will be having low frequency SNH in early stages. So therefore there will be rising curve. Which curve? Rising. How to remember? Meanier rising. Age sloping. Let's see over here. Meaniers. For God's sake, never do in the paper, oh, very easy. There is an AB gap, it's a conductive hearing loss. No. Don't do like that. I trust you. You are very smart people. You never do like this mistake, beta. There are two ears, beta. Red for right ear, blue for left ear. My dear friend, right ear. Please see, the right ear is absolutely normal. Left ear has SNHL, beta. Meanius is a unilateral disease. Right ear is normal. Left has got the problem, beta. And can you see a beautiful rising pattern? Meanius is rising curve. Meanius rising curve. Two things over there. Meanius unilateral disease. Right ear is normal. Left ear has got SNHL, and I can see the clear rising pattern over there. Okay, and please see presbycusis. Presbycusis sloping curve. Sloping. Can you see with a sloping curve? Both sides, right and left. Right for red for right, blue for left. Both are coming down. Presbycusis is a bilateral disease. It involves both the ears, and patient is having sloping audiogram beta because it's a high frequency more loss in the early stages. So these are the important revision points out of our app videos and class lectures out of otology segment. Okay, thank you very much and God bless you. May you excel in your exam and I'm sure you will do very well.